Good morning, everyone. Hello. How are you all?
Good, ma'am.
And we have our ophthalmologic expert, Dr. Ritesh. Good morning, Dr. Ritesh.
Hi, good morning.
Okay, so thank you for joining this meeting. Now we are resuming our course. I'm saying our course because when it comes to learning, we all are learners, right? So it's a kind of win-win. It's a mutual benefit. I learn from your interaction, from your questions, and I hope you can learn something new from me and also from Dr. Verma today. I do promise that this is going to be the last part regarding proptosis evaluation. This is the fourth part, and personally, I got bored from talking about proptosis for such a long time. So now, today, we are going to end this topic, hopefully, inshallah. And I'll start by a quiz. For those who are new, this presentation is interactive. Just a reminder that you can raise your hand whenever you want me to repeat something or to ask a question or anything. Okay, and especially for Dr. Verma, if you want to add anything or have any comment, please go ahead. So I posted this question before, but let's repeat it again. Personally, I hate this question, and I don't expect that anyone could be asked this question in the FRCS exam, but maybe in some national exams, some of professors may be interested to ask you about these signs, by names, by the name of the scientists. And I remember this question when I was an undergraduate student. I really hated this question, and I do believe it's important to know the sign, the descriptive meaning of the sign rather than the name of the scientists. But anyhow, maybe in order to show our respect to those scientists who exert a lot of effort and time to elicit these signs, we mean interested to know these signs by names, okay? Okay, so my first question for you today is, let's give me the title for this slide. So in this slide, we have a number of photos, as you can see, and we have names like number of signs. We have 6 clinical signs, but we have 5 clinical photos. So just give me on your chat, your main interactivity on chat until I advise something else. So just write on the chat, what can I write in this tab as a title for this slide? This is a question like matching the sign with the photo. But let's write a title for this slide. Okay, thyroid eye signs or ocular sign, exactly. So let's see it right now. Okay, so the next question is to match. Because I want to solve this question quickly, as we already solved it before. So let's answer it together. So let's start by this photo. All the photos were taken from the Google, so they are not my cases, of course. I don't see such cases. So in this photo, I'm going to describe. So this is little a. So the first one here. Here the examiner is asking the patient to follow his finger, to look down from up gaze to down gaze. And as you can see, both eye globes are descending, are depressing downward, but the eyelids, both upper eyelids, are lagging behind. Okay, so generally speaking, in summary, we have lid lag on down gaze. So this is the sign. My question now, what is the name of this sign when we have lid lag? Yeah, exactly. So lid lag on down gaze is von Greve sign. I don't know exactly the exact pronunciation, but if you know, good for you. So I usually say it von Greve sign. So how can I memorize this? Let's see. If I have a trouble, so this is what I did when I was an undergraduate, because all these names are foreign names for me. So first I have to memorize the names and the spelling, and then to match the sign with the name. So a lot of effort. So we have here lid lag. So as you can see, it's like 2 words, lid and lag. So which of these signs, which of these names have 2 names? It's von Greve. So this means this is von Greve sign. Okay. So this is how I memorize this sign. Lead lag on down gaze. So of course, we are talking about lead lag and down gaze in a thyroid patient, in thyroid eye disease patient. Okay. So this is number one. Let's go to this next one. And letter B here. Here the examiner is asking the patient to converge. Okay, so the examiner is holding a pen. I suppose that he was bringing the pen from a distant nearer to the patient, and the patient is asked to converge on the pen, and there is a kind of lack of convergence or weak convergence on the pen. So what is the name of this sign? Yeah, exactly. So how can I memorize? So since we have lack of convergence, this reminds me of what? Of strabismus, modality problem, strabismus, okay? So if you remember, we have an important syndrome in strabismus and neuro-ophthalmology. It's called what? Mobius syndrome. It's totally different from this sign, but it still carries the same scientists, okay? So this is just a reminder that this sign is a Mobius. So lack of convergence, no. So here, so lack of convergence. Again, in thyroid eye disease patient, this is Mobius sign, okay? So this is letter B. Now coming to the most important sign in thyroid patient, okay? In this photo, let's discuss this photo, letter C, okay? So we have here eyelid retraction. How can I know this is an eyelid retraction? So it's a kind of revision. If you are following the previous classes, you will know. So how can I know this is an eyelid retraction here in upper eyelid, for example? So in upper eyelid, because first, the tarsal show, remember what's the meaning of tarsal show? Let's say the other side, because the other side apparently looks normal. So this is like a normal width, the normal vertical width of the tarsal show, okay? But here it is hidden. It's almost absent because of extreme eyelid retraction. So this is a sign that there is eyelid retraction. Also, whenever there is eyelid retraction, now the upper part of the cornea is exposed, and you can even appreciate the presence of the superior scleral limb. So this is another effect. So the third effect, if you measure the vertical palpebral fissure, it's widened. Okay, all of these due to the upper eyelid retraction. Okay, so in thyroid patient, when we have an upper eyelid retraction, so by the way, you can say upper and lower, but we usually focus on the upper eyelid. So if we have an upper eyelid retraction in thyroid patient, we have a rim of the sclera. So what's the name of, and we have widened palpebral fissure. So what's the name of this sign? By the scientist's name. Yeah, exactly. So we can write now. How can I remember this? By the way, this is probably the most important scientist name. If you want to just memorize one scientist name, just remember this name, Darlimber sign. So since we have rim of sclera, because of upper eyelid retraction, so if you notice here, the word rim here, it's like sound, have the same sound like rim here in Darlimber signs, like in phonetics, so it have the same sound like the middle syllable here in this, again, once more, so rim of sclera. So we have Dar, again, rim. So I will write it down like rim in order to remember. So this a reminder of the name of the sign. Okay. Okay, we finished now like 3 signs. By the way, Darlimber sign is present in more than one photo, but this is how I answered this question. Okay. Let's see, like letter D here. So we have sign. Personally, I don't feel it's important, but anyhow, we have like extreme upper eyelid retraction, bilateral, and upper and lower. Okay, and it gives the patient like a stirring look and freaking and frightening appearance. It's something bad. It's something frightening. So what's the name of this sign? Yeah, it's kohar. So for me, I don't know if you have an Arabs here. I have my own way to remember this sign, but using Arabic language. So yeah, I would have an Arab here. So here we have an Egyptian slang word. It starts by this sound. Like we say it kokhar. By the way, I say it's kokhar sign. I don't know if this is correct or not, but we have a similar word in Egyptian slang started by the same sound, and it means bad. It means stay away from this thing. So that's why I remind myself that this freaking appearance is called kokhar sign. Okay. All right. And now coming to this one. This one is the most important one, and I learned this sign from Dr. Verma, by the way. I may share with you a story because I'm very grateful because I learned many things from Dr. Verma, although I attended few classes with him. So here, when we have an upper eyelid retraction, okay, let's make some drawing here. So if you are good at drawing or just by observation, so normally if I draw here the upper eyelid, normally it should be like this. So apart from the level, so normally the upper eyelid should cover about 2 millimeters, the upper 2 millimeters of the cornea. So this is like the normal level of the upper eyelid. But also the pattern or how we draw. So the temporal part of the upper eyelid should be lower, okay? Should be lower than anything else. But here, in thyroid patients, we may get this sign, okay? Where the upper eyelid retraction is maximum at the temporal part, okay? So we have like eyelid retraction. So it's a kind of subtype of eyelid retraction. It's a kind of subtype of eyelid retraction where the lid retraction is maximum temporally. Okay, so what's the name of this sign if we have an eyelid retraction that is maximum at the temporal part? What's the name of this sign? Yeah, temporal flare. Luckily, we don't have any scientist's name here, or just a descriptive sign, which is the temporal flare. So I'll share with you some story because at some point you may self-study. So when I was a resident, when I first time came across the word temporal flare, okay? So I thought temporal flare has another meaning until I attended Dr. Verma like 1 year ago, I don't remember. I realized the actual meaning of temporal flare. I will share it in a few minutes. But temporal flare, we will describe in a moment what's the meaning of flare, by the way. But here the description is the upper eyelid is maximally retracted temporal area. And there are some theories explaining why. Okay. If you notice something here, we finished this only 5 signs, okay? Darlimpel, Mobius, von Graefe, Kocher, and temporal flare. But still we have one sign. So do we have a photo for this sign, still wax sign, or not? Can we have a photo for still wax sign? And if no, why? No, we can't demonstrate still wax sign. Why we can't, demonstrate it on a photo, in a still image? Yeah, because we need at least 2-minute video clip. Yeah, because it's infrequent blinking. You have decreased blink rate in patient of thyroid, and this is the name of the still wax sign. Easy peasy. Okay, let's go to the next one. Okay, so as I said before, this is a bad question. Okay, so let's take it to worse. Yeah, so I'm just kidding. I'm going to again revisit this question, but in my way. So hopefully I will bring it from bad to beautiful. Let's see. First, I asked before the first question to give me a title. Actually, this slide doesn't demonstrate all the thyroid eye signs. We have like constellations of many signs for thyroid eye disease. We have active stage, we have chronic stage, and we have many classifications. Of course, you know this better than me. But for example, there is no mention here, although it's present in some photos, there is no mention of proptosis. For example, there is no like a written word about proptosis. So still we have many other signs. And if you're studying from Kansky, you will find another signs. Okay, there is no mention about strabismus. So the correct title for this slide is Some Ocular Signs in Thyroid Eye Disease. Okay. And let's ask Dr. So let's attack some Mumbai members. Okay. Good morning. How are you?
Good morning, ma'am. I'm good. How are you, ma'am?
Okay. So we call it thyroid eye disease, okay? Does thyroid affect the eyeball itself?
Yes, ma'am.
How?
Um, it might lead to inflammation and muscle enlargement.
So muscle is a part of the eyeball. It's called ocular
Yes.
adnexal.
Yeah.
So it's not
Okay.
an ocular
Okay.
component. It's like something adnexal, like associated with the globe. Okay. And you
Okay.
said
Okay.
inflammation, and then it stopped. So inflammation, what do you mean by inflammation? Uveitis, conjunctivitis, scleritis?
No.
So just to continue, what is the inflammation here? So thyroid eye disease is like under the heading of inflammatory disorder, okay? Autoimmune inflammatory
Yes.
disorder.
It's an autoimmune. Yes.
Yeah, but inflammation at which level? What are the structures that are affected by inflammation?
Mainly the extraocular muscles.
So extraocular muscles, this is number one.
Then
Okay,
okay.
so
Okay.
so the eye globe itself, like the layers and the contents of eyeball are not affected in thyroid, but why we call it like thyroid eye disease? Yeah, just to think, you don't give me the examiner long pause. You have to think quickly. So this is just a brainstorming question. I just want to share it with you in order to help you in differential diagnosis. So thyroid doesn't cause uveitis, for example, okay? It doesn't cause any inflammation of any layers. But what is but the eyes eventually can be affected, hardly, like massively, and the patient may lose vision, okay? But not because of inflammation of the globe, but due to other secondary effects to the surrounding structures, because of the surrounding preocular inflammation of the muscles and the adipose tissue, and the pathophysiology. We have like sight-threatening complications that involve the globe itself. So if you didn't manage the thyroid patient promptly and effectively, the patient may end up blind, okay? So what are the sight-threatening complications in thyroid eye disease? So I know this is a mock clinical and not mock viva, but they are all connected. Because the first step in clinical exam to solve the problem, to solve the case, and then you have a follow-up questions. So what are the sight-threatening complications in thyroid eye disease patients?
exposure keratopathy.
Yes. Number one. Number two?
Optic nerve involvement.
Exactly. Thank you. So interestingly, because you may find differential diagnosis of a patient with thyroid eye disease. So very important that thyroid eye disease doesn't cause uveitis, okay? Doesn't cause lacrimal gland involvement, okay? If the question was about the eyelid signs in thyroid eye disease, what are the eyelid signs? So here we are specifically asking about the eyelid signs in thyroid eye disease. Number 1, 2, 3, just give me 3.
Hi, Dr. Lana. Eyelid retraction, eyelid erythema, and swelling.
Okay, excellent. What else? Because sometimes, I imagine this situation that the examiner has like a key words, like key answer words. And sometimes they are confronted with like an excellent candidate who added more information, gives the examiner like out of the box answers. They are correct, but still missing some of the key answers. So don't be surprised that the examiner will need more additional answers because he want to fulfill all the answer key in his like cue card. Okay. So you said edema and erythema. This is like soft tissue involvement. Correct. And we have eyelid retraction. Okay, you can add some like upper, lower, and bilateral, unilateral, yeah. And what else? If you remember the previous slide, the bad slide.
Temporal flare.
Yeah, temporal flare, you can add it because it's a subtype of eyelid retraction, but it deserves to be mentioned specifically. And what else?
Lid lag.
Yeah, exactly. So let's see the next one. Thank you, Dr. And this was taken from CyberSite lecture. Here, eyelid signs collectively, we can say like eyelid retraction, lid lag, and temporal flare. We can here add soft tissue involvement. Okay. So I always believe that the best answer is the answer given by a lot of people. Okay. And very important that if you have like upper eyelid retraction and lower eyelid retraction, is highly suggestive of thyroid eye disease. Okay. And now let's see the next still wax sign. So this is like an additional follow-up questions. It's not related to thyroid, but in order to increase the depth of knowledge. Okay. So we said before, still wag is infrequent blinking, as you said, but what is the normal blink rate?
Normal blink rate is around 10 in 1 minute.
Yeah.
10 to 15 in 1 minute.
So whenever we say 10, you have to say 10 what? 10
10
seconds?
blinks in
yeah, 10 blinks.
10 blinks in a minute.
In a minute, yeah. So we have, you said the median number, or let's say the average, but we can say in a range like from
10
12
to 15.
Yeah, 12 to 15 blinks per minute, or we can say we can blink after like 3 to 4 seconds. Okay. So of course, whenever we have normal, we have variation like abnormalities. So we have some disorders that can cause increased blink rate, and we have disorders that decrease the blink rate. Okay.
Yes.
So can you give me one example of decreased blink rate other than thyroid eye disease?
Parkinsonism.
Yeah, well done, excellent. Okay, thanks, Dr. Verma. He said that you can, it's equal to the respiratory rate. Yeah, nice tip. Okay, so if you check Parkinson's disease, you will find two opposing videos on YouTube. One about decreased blink rate, okay, and another one about increased blink rate. Sometimes because of dryness, and yeah, you have like paroxysmal, like paradox response with increased blink rate. So you will find Parkinson's disease under the heading of increased blink rate and decreased blink rate. Okay, and Parkinson's disease is important disease in neuro-ophthalmology. By the way, you have to know some general overview about this disease and the ophthalmic manifestation of Parkinson's disease. Okay, and now let's see von Greve sign, which is lid lag in down gaze. So if you remember this video, I slowed down the video, the speed. You first test the up gaze and down gaze without holding the upper eyelid, because you want to comment on the dynamics of the motility of the eyelids, the upper eyelids. Generally, we are talking about the upper eyelid, okay, because the upper lid is a well-developed eyelid and with a large range of movement. So this is how we test for lid lag for thyroid eye disease, okay? So here I'm not commenting on motility, because in order to comment on depression, you have to elevate the eyelids by your hand, by your fingers. But here I'm just looking at the free mobility of the upper eyelid from up gaze and down gaze. Okay, so here, as you can see in this photo, you can appreciate that the tarsal show here is narrow because of eyelid retraction. So eyelid retraction here, and the patient here is looking down, and there is lag of the upper eyelid behind the globe. And as you can see, also the rim of the sclera is visible. So this demonstrates the lid lag on down gaze. Okay, by the way, thyroid eye disease can cause lag of thalamus per se. So we can find lag of thalamus. If you ask the patient to just gently close their eyelids, you may find lag of thalamus. So lag of thalamus is one of the signs of thyroid eye disease, but here we are talking about lid lag on down gaze. So please don't confuse between both terms, between lag of thalamus per se and lid lag on down gaze. Okay. Here I'm showing that this is like the upper eyelid here is descend normally, but here we have retraction, we have lagging. Okay, and this makes the lid retraction more evident in down gaze. Okay, you know, sometimes the lid retraction is evident in the primary position, but if we have also lid lag on down gaze, this makes the lid retraction more evident, more apparent. Okay, let's work together. So what are the other causes of lid lag on down gaze? So we just mentioned one common cause, which is thyroid eye disease, von Greve sign, so lid lag on down gaze. Do you know another causes that can? Yeah, perfectly done. Okay, perfectly said and written. So yeah, congenital ptosis. And I like your answer because you didn't say just ptosis and that's it. You said the congenital ptosis, and you can add dystrophic ptosis. So congenital ptosis and exactly. So do you know why?
Due to levator dystrophy of the levator muscle.
Yes. So in congenital dystrophic ptosis, we have like the pathology is involving the levator aponeurosis. We have fibrofatty degeneration. So we have weak muscle. We have the muscle is weak. So that's why we have ptosis. And we also have delayed relaxation. So the muscle doesn't relax freely. And in down gaze, we need the relaxation of levator. When we look down, the levator muscle must be relaxed normally. So in congenital ptosis, we have problem also in relaxation, and that's why we have lid lag on down gaze. Okay, so normally when you look up to the ceiling, both upper lids should retract backward. Okay, and when you look down, both upper eyelids should descend. Okay, this is a normal dynamics of the upper eyelid. Okay, so once more, in congenital ptosis, we have weak levator, and that's why we have ptosis. And we have also problem in relaxation. And that's why we have lid lag on down gaze, because in down gaze, we need relaxation of the levator. And another cause, you can say it by logics, if we have a scarring, like cicatricial, something holding the upper eyelid, like retraction of the upper eyelid by scar, you know, or like cicatricial ectropion of the upper eyelid. So again, definitely there will be the eyelid doesn't move freely downward. So here the video shows 3 cases of ptosis. I brought this video because of the congenital ptosis. So here, it's all about the first case. We have like congenital ptosis with dystrophic levator, okay? So as you, in the primary position here, you can appreciate there is like ptosis here, okay? Upper eyelid ptosis. Here the patient is looking up, okay? The patient now is looking down. So see here there is lid lag. If you compare the eyelid position here, the left side to the right side, you will find lid retraction. So lid lag on down gaze is a kind of lid retraction on down gaze, okay? Because the eyelid doesn't descend freely, okay? So you can view lid lag on down gaze as a lid retraction on down gaze, okay? One more time. Okay, so this just to show you the lid lag on down gaze in congenital ptosis. By the way, we're still in the quiz at the beginning of the presentation. This is still the warm-up slides. So let's share with you my story regarding temporal flare. Okay, so flare has 2 meanings linguistically, so have 2 meanings for flare. Okay, first one that I thought when I was a resident, which is just redness. So I thought temporal flare, I thought when I was a resident, until many years afterwards, that temporal flare is just hyperemia, okay, like in the temporal area. Okay, this is like my translation back then. But actually, and if you remember, we have aqueous flare. Anyhow, but flare has another meaning, okay? So flare, this is like the style if something is widened, like becoming wide, this is called the flare. And the shape of the baby's mouth here is called the flare. Something that means widening, flaring, like widening. Okay, so actually the meaning of temporal flare, as we shared at the beginning, is widening of the palpebral fissure laterally or due to widening or due to maximum retraction of the upper eyelid. And this is a pathognomonic of thyroid eye disease. So whenever you have an upper eyelid retraction, and we appreciate this widening at the temporal part, because of maximum retraction, this is highly suggestive of thyroid eye disease, unless pathognomonic. It may be pathognomonic, okay? And it's one of the diagnostic criteria, as I remember. So this is the meaning of temporal flare. Okay, so it is an altered contour of the upper eyelid is pathognomonic sign, and it occurs due to, this is the pathology, so this is scarring of the lacrimal fascia and levator. It might be hyperemia at first and then results in scarring, but this is the meaning of the temporal flare. Okay, I'm showing here the normal contour and of the upper and lower eyelid, but in thyroid we have distraction, we have upper eyelid distraction, this is number 2, and we have temporal flare, and this is the sign. Okay, so what is important of this? Sometimes if you have a case in the clinical or maybe a photo in the Viva, and you have a case of like proptosis, let's say proptosis or eyelid retraction, sometimes the answer should be a list of differential diagnosis, okay? But other times you have to give them a single diagnosis if the photo or if the case shows a pathognomonic sign. So for example, in a patient like this, we have like upper and lower eyelid retraction, we have temporal flare, we have hyperemia at the insertion of rectus muscles. This is, and mostly we have also proptosis, and and this is bilateral. So this is a very highly suggestive. This is like a thyroid. So here, the examiner is generally expecting one single answer, like thyroid patient. Okay, but imagine another scenario: a patient with unilateral proptosis. There is no clue for the cause. Here, you should give the examiner a list of differential diagnoses. Okay, so try to differentiate whether the case shows a pathognomonic sign. So you should give the examiner a single diagnosis, okay? Or the case is like a puzzle, it's vague. So in such a case, you have to give the examiner a list of differential diagnoses. Okay, so here, if you're going to answer this question because of the following signs, this is mostly a case of thyroid eye disease. And you will find that the examiner is asking you next about the thyroid eye disease questions, okay? Because you already have given the examiner what he wanted, okay? A Mobius sign, testing of convergence is important. So testing of convergence, we will need it in strabismus evaluation, but also here in thyroid. Okay, so testing of convergence, we don't test for conversion as a routine, okay, step. But sometimes there are some disorders that we need to test conversion. Like, since we are talking today about proptosis and evaluation, so we mentioned thyroid eye disease, Mobius sign, when we have like lack of convergence. So again, we need it in strabismus. Especially, I will say it because we are not talking about strabismus like in XT, like something called convergent insufficiency, exotropia. And we have an important disorder in neuro-ophthalmology where you should test for convergence, and it's really important. So can you tell me what is the name of this disorder? It's really important to test convergence in such disorder.
Madam, it's Addis and Argent-Robertson pupil.
Okay, say it again.
Addis pupil, Argent-Robertson pupil.
Okay, so what's the abnormalities here in Addis pupil?
Addis pupil, madam, light near dissociation is there.
Okay, so light near dissociation. What's the meaning of light near dissociation?
Light near dissociation means, madam, people normally not reacting, but when we do, when we check the near reflex, then people constrict.
Okay, so it's about pupil, but here we are talking
madam.
about convergence.
Okay, madam.
So it's confusing because I asked this question before and I got your answer before. So light near dissociation, in order to demonstrate it, we need to do near reflex, but we are focusing on observing the pupil for constriction. Okay, so in Addis pupil or light near dissociation, the pupil doesn't react normally to light, but it reacts briskly to accommodation. So it's accommodating nicely. So here it's all about pupil, okay? But here I'm asking about testing convergence to check for lack of convergence, okay? To check for abnormality in convergence. So we said thyroid eye disease, this is number 1, and something called convergence insufficiency, as the name implies, exotropia, so convergence insufficiency. And we have another thing, And I think someone said it, yeah, I know. So internuclear ophthalmoplegia. And it's really important to check convergence in internuclear ophthalmoplegia, because if you remember, this is a really important topic in neuro-ophthalmology. You need to study it very well. So you have in INO, without going to much details, you have defect in movement, adduction of the eye. But you need to test convergence because if the convergence is intact, this proves the diagnosis of INO. Okay. Although in some cases of INO, you will find lack of convergence also. Anyhow, at this point, you have to write in your notes. I hope everyone has notes. Everyone is taking notes right now. Just write down, I need to revise INO. So INO. Okay, so what happened right now with doctor, that sometimes you give the examiner an answer. You thought this is the correct answer, okay? It happened all the time. But actually, you just were confused, okay? So you will, from the response of the examiner, you will know that you need to rethink again. So don't lose hope and try to rethink quickly again to find out the correct answer. And this is why we are practicing right now, because we are here to practice. Are you tired? Because I'm tired. So are you tired? Get bored? Okay, if you are tired, that's not problem. But if you are bored, I may end the presentation because boring is something awful. Okay, Dr. Ritesh, do you want to say something?
Yeah, I don't think it is boring. It is very interesting for everyone.
Oh, this is your only comment?
Yes, ma'am, very
Yeah,
interesting.
and I also want to add on something like that video you showed where there was written the vector dystrophy.
Yeah.
So I also used to say that it's dystrophic muscle, it's dystrophic because it is causing ptosis. But now I always say that it is agenesis and dysgenesis as compared to atrophy and dystrophy. Because if you see the definitions, the dystrophy means something which is wearing out, like the aging process. And dysgenesis is something which has not formed. So I think that dysgenesis is a better word as compared to dystrophy in that scenario.
Okay.
And
So
also the discussion we are having since uh, since the beginning of the class, I just want to tell that these eyelid signs are just a proxy measure of what is going on in the orbit. So actually, if you see the newer classifications, they are not considering all these signs. It is definitely a part of our curriculum because it has been written in our books. But the clinical activity score and visa classification and the UGOGO group, they in their papers they don't use these terms anymore now. So I don't know. These terms are in the book, and examiners they want to know us these signs, but it will take a long time for these signs to go out from our books. These names of the scientists, and we have to remember these. And this is somehow our curriculum now, which has been a part of FRCS for long now.
yeah, that's why I said it's a bad question.
Yeah, and also if it was up to me, I would change the name of the disease to thyroid orbital disease, because this disease is mostly dealt with the endocrinologists. They find it easy to call it thyroid eye disease because everything in the orbit is eye to them. So that's why even the UGOGO guidelines which are given for the treatment of thyroid eye disease have been given by endocrinologists, not by the ophthalmologists. So that is why it is called thyroid eye disease and not thyroid orbital disease. And I think this will wake up most of those who are sleeping, and then we can continue.
Yes, okay. Thank you, Dr.
Okay.
Verma. So here, this slide is about, so SNS here means sometimes we focus only on the signs, okay? But you need to know the symptoms. So if I ask you now, what are the symptoms of thyroid eye disease? So again, this presentation is not about thyroid eye disease. I am the last one to talk about it. It's not my specialty, but anyhow, just quickly on the chat, yeah, just write down what are the possible symptoms, okay? Because sometimes for classifications or grading of the severity and giving a score for thyroid eye disease, we sometimes ask the patient about symptoms. So you need to know the symptoms of the patient. And if you're reading some of the experience, you will find some of the examiner's questions. Some of the questions are about what do you think the patient is complaining from? This is a style of questions. Sometimes the examiner asks the candidate, do you expect the patient complains of blah blah blah? So you need also to focus about the symptoms. We understand that we focus on signs because this is how we diagnose the case in clinical exam, since there is no history, but sometimes you need to know the symptoms. So just give me like at least 3 symptoms of thyroid eye disease patients. Number 1. Okay, so dryness is not a symptom. So dryness is a diagnosis. So you have to change the word to symptom. Blurring of vision. So we can say we have, let's take it number 2. We have visual. Okay, so in visual, you can say blurring of vision. So we are talking about diminution of vision. Okay, and so number 3, soft tissue. So soft tissue like redness, okay, redness, congestion, swelling. So do you mean cosmesis? So if you are saying just redness and swelling, you mean cosmesis. And someone said pain. So if I ask you right now, if the examiner asks you what are the causes of painful proptosis, shall we put thyroid eye disease? Another way, is thyroid eye disease is one of the causes of painful proptosis? So do we have pain in thyroid eye disease? So someone said no, it's a kind of painless. So sometimes we divide causes of proptosis into painful and painless. Where we can put thyroid eye disease, under the painful or painless? So this is actually a confusing question. It depends what kind of pain. But generally speaking, some practitioners don't like the word pain in thyroid eye disease. They usually say it's a kind of discomfort or irritation. It's a kind of mild pain, okay? But again, if you are seeing the questionnaire and the scoring system for thyroid, you will find pain. Sometimes we have pain with ocular motility. So there is some kind of pain, but it's not that painful, okay? So it's something in between. But it's not totally wrong to say there is some pain in thyroid eye disease. And we have, yeah. So I was waiting for here, someone said also here, let's say number 4, like proptosis or like prominent eyes. Okay. Again, so I was waiting for diplopia because this is one of the commonly asked questions in the FRCS exam. They are very focusing and stressing the importance of asking about diplopia, okay? And even in the management. So don't forget that the patient may complain of diplopia and you have to ask them about this diplopia. As you can see here, I wrote irritation, discomfort, because when we are going to treat thyroid eye disease, if we have like mild thyroid eye disease, the mainstay treatment of to give ocular lubrications, okay? Because to relieve such discomfort and such irritation from dryness, from the exposure, because we have eyelid retraction, we have proptosis. So don't ever ignore this simple line of treatment when we are talking about the management, to give ocular lubrication. Sometimes the case needs only just lubrication in mild cases. So never underestimate the value of lubrication in management of thyroid eye disease, okay? So this is the message of this slide. Yeah, good morning. So my question is for you is not about the photo of this lady, it's about this turtle, okay? Does this turtle remind you of something?
I should say slow and steady wins the race, the story of the rabbit and the turtle.
Okay, so can you relate to this, relate this photo to our presentation, to our topic?
Yeah, yes, the thyroid eye disease, it's progressive. It's not rapid, it's gradually progressive.
But sometimes it's cerebrally. We have variation in the presentation, by the way. But okay,
Yes.
so anything else? Does turtle remind you of something? Do you have? Yeah.
The lid lag.
Okay. Let's see the photo. It's more practical. So let's see this lady. So this again from a reference. Can you comment on the photo at the bottom?
Yes, the right eye is showing scleral show in the down gaze, and the left eye, when we see it's
so one second.
Yes.
Hang on, please wait. Okay, I know this is about strabismus, but anyhow, this is you have to first decide whether the patient is where is the direction of gaze. Okay, so do you think here the patient in this at the bottom? Do you think the patient is looking down or looking at the primary position? What do you think?
I think it's primary position, yes.
Okay, as long you think it's a primary position, so there is no place to say on down gaze. Okay, there is no down gaze in this photo. Okay. So I'm going to help you because this is about somehow strabismus. So here again, this is a primary position, and the left eye is apparently the normal eye. Okay, and the normal eye is fixating on the light. So the abnormality is on the right side. Okay. Now keep going. So here you started your answer wrongly. So be careful because this is not a down gaze at all. It is a primary position. And now mention the disorder here or the clinical sign.
So there is right hypotropia as well as there is scleral show, there is lid lag.
Okay, one second.
Upper lid retraction.
Okay, 1 second. Let's focus on the most important one is hypotropia. Okay. Now, if we have hypotropia, you know Hirschberg test? Hirschberg test, I discussed in another series. So if the corneal light reflection is centered here, but here is decentered, let's say upper. So if we have a hypotropia, we have Hirschberg test is decentered upper. It's a little bit up and the end, but ignore the end component, it's up. So you can start by this. It's a photo of a lady, maybe 50 years old, fair complected person, lady. So we have in the primary position, there is right hypotropia. And Hirschberg shows centered on the left eye, this is a fixating eye, and decentered up in the right eye. And the amount of decentration, if you want to add, the decentration is at the pupillary border, and this approximately 15 degrees. So we have like 15 degrees of hypotropia. Because here the pupil is of average size. So 15 degrees of hypotropia, if you want to say it in prism, equally like approximately 30 prism diopters, okay? When we have hypotropia, so just imagine hypotropia means the eye is like deviated downward. It's like it's moving down. So logically, the upper sclera will be shown. But sometimes we have pseudotosis, but generally speaking, in restrictive hypotropia, we don't have pseudotosis. But here, if you are going to comment on the upper eyelid retraction, look at the tarsal show. The tarsal show in both sides is almost equal. Okay, so if I were you, I don't know if Dr. Verma would agree with me, but if I were you, I will focus only on hypotropia. Because lid retraction here, maybe there is bilateral retraction, by the way, because for me, the upper tarsal show is narrow in both eyes. And there might be proptosis, who knows? Okay, maybe. But in order to confirm the presence of proptosis, we need Worm's view or Nafziger, or we need measurement by Hertel. Okay, but this all the eyelid retraction and proptosis are not significant or not clear in this photo. The most important, like the most salient or the most manifest sign here is hypotropia. And now if you correlate with the upper photo, the patient is asked to look up and there is limitation of the up gaze. Okay, so we have here limitation of the up gaze. So collectively, this patient has hypotropia on the right side with limitation of up gaze. Okay, this is the thyroid eye disease, but if it's in this case in the exam, okay, you have to give the examiner a list of differential diagnosis. We are going to talk about this in strabismus, because if we have hypotropia and limitation of upgaze, it could be restrictive or it could be paralytic. But since we are talking about thyroid right now, actually this is a case of inferior rectus restriction in thyroid patients, and we have hypotropia. Okay, this is the answer key of this photo. So please, can you read aloud the legend, the comment here?
Note the vertical misalignment of the eyes in primary gaze and the restrictive movement in the upward gaze. This is due to an enlarged and restricted inferior rectus muscle.
Okay, thank you. So this is a comment because here the author, this is taken from the Iowa, knows the case. Okay, knows the case. But if we have such a case, this photo in the exam, you have to make a differential diagnosis. Don't say, for example, don't say restriction of the upgaze. Say limitation of upgaze, because it could be paralytic. Who knows? Okay,
Yes.
But since this is a non-reference and the author already knew the case, he said there is a restriction of inferior rectus and this is a restrictive upgaze. So actually, the significance of turtle in proptosis comes from this mnemonic. I'm slow. I'm slow, so you know turtles are slow. So I'm slow is a mnemonic to remember the order of extraocular muscles involvement in thyroid eye disease. In the restrictive, because the pathology in thyroid eye disease in the muscles is restrictive strabismus. Okay, so the most commonly affected muscle is inferior rectus. This is I, and then medial rectus this is M, and then superior rectus this is slow S, and then lateral rectus, and the least affected muscles are obliques. So here in thyroid eye disease, in the fibrotic stage, we have a kind of restrictive strabismus. Okay, and we mentioned the order: inferior rectus, medial rectus. I'm slow. Okay, shows the order of affection. Most commonly affected muscles are inferior rectus and medial rectus. Okay, let's see Dr. Trick someone here, Dr.
Yes, madam.
Okay, so Marhan.
Good morning, madam.
Good morning. So just fill in the gaps. In thyroid eye disease, the most commonly affected gazes are, and yeah, fill in the gaps.
Gazes most commonly are vertical gaze.
Yes.
And then horizontal gaze.
Okay. Do you think this is a specific answer? We usually don't say, because we have vertical gazes and horizontal gazes. So these are the gazes we have. So try to be specific, like we have up gaze, down gaze. So
okay.
Here,
inferior gaze, then adduction restricted, then upward restricted, then lateral restricted.
Okay.
Abduction restricted.
So I think you give me like 4 answers now. We have 2 blanks spaces. So try to focus, okay? And give me 2 keyword answers. So you have 4 options, okay? Up gaze, down gaze. So we don't say, usually we don't say inferior gaze. We say down gaze, okay? So up gaze. So when we are talking about strabismus from the oculoplastic point of view, we try to simplify gazes. We just say up gaze, down gaze. What can I say? Like nasal and temporal
okay,
gaze.
Madam. Then down gaze, nasal gaze, up gaze, and temporal gaze.
We have just 2 spaces here. You have, can you see? We have 2 spaces here. Okay?
Yeah, madam.
Just give me 2 gazes which are the most commonly affected in thyroid eye disease. Okay.
Then down gaze and nasal gaze. Down gaze and nasal gaze.
Okay. Hold on. Here in this area, what are the most commonly affected extraocular muscles? Okay. Okay, please don't say all the muscles. Just give me 2 muscles.
Madam, inferior rectus and medial rectus.
Okay. Okay. So if the inferior rectus is the most commonly affected muscle, which gaze is affected?
Down gaze and up gaze also.
There is nothing called up gaze also. You have to choose one.
Down gaze.
Okay, so what's the meaning of inferior rectus restriction? It means that the eye is tightened and like tethered and taken down. Okay.
Oh, madam,
So
then up gaze restricted. There will be up gaze restricted.
okay, so here, so actually the eye is already in down gaze. So sometimes there is no point of testing the down gaze because the eye is already down. Okay, so it's up gaze. And here, what shall I do, right? And if the medial rectus is restricted, like taking the eye inward, so what is the affected gaze here?
The temporal gaze.
Okay, temporal. Or let's say the abduction, let's say. Okay, so and this is the general rule for in restrictive fibrotic strabismus. If you have one muscle is affected, the opposite gaze will be the affected. If you remember blowout fracture of the orbital floor with incarceration of the inferior rectus. So what is the gaze is affected? The up gaze, okay? Because, got it?
Yes,
Hey.
madam.
Okay. So because sometimes some candidates confused about this because they said what you have already said. Since it is inferior rectus and medial rectus, they say the down gaze and nasal gaze, but actually it's the opposite, okay? And again, this is like a basic knowledge in strabismus. All right, good job. Thank you, Doctor. Hey, we finished the quiz, by the way. So this is, we finished the warm-up slides. And I said before that this is the last part. I'm not going to do another presentation about proptosis. We will see how we can finish this presentation. We will have many breaks. Okay, so I shall end the presentation at the point you said I'm bored, okay? Okay, so instead of showing you some cases, I'm just served some past candidate experience, okay? And if you remember this slide, I mentioned in the first part of this series that we have a treasure, and it's open treasure, and it's available everywhere, which is the past candidate experience. But you know what's the problem? The problem lies in two things. The first thing is some experience, unfortunately, were written not well written, okay? And some experiences actually sent a negative image, like a negative message, okay? So try to ignore this aspect and try to bring the best out of every experience. Even if the experience is like 2 lines, at least you have get an idea about the cases, okay? About the topic, at least the topic, not only the topic. This is the first issue regarding past candidate experience. The second part is that sometimes this is a kind of a study source, okay? So you need to study the candidate experience. What I mean by this, don't just read rapidly or like surfing the experience. Try to live the experience. Try to imagine yourself that you were this candidate, okay? And try to give the well-written, articulate answer for each question. And try to imagine what could be the other questions, because some candidates didn't write everything, because some of them forget about all the questions. Okay, so try to spend maybe a few hours in just one experience. Try to explore all the possible questions and the related topics, okay? Because if you just read this experience without practicing answering the questions, it's like you are reading the index of a book. Is it enough? No, it's not enough ever, okay? So let's start by the first case based on past candidate experience. And this case was taken from this old book. This is an very old book before some of you were born. We have this patient. Okay, since it's a difficult case, I will show additional clues. If you have any thoughts at this point, you can write it on the chat. So this is another clue. So these are his hands. And this says something. This says that sometimes the examiner, gives you a clue to examine other parts of the patient, not only the face, not only the eye, but also maybe he gave you a hint to examine his hands. Who knows? So be careful about having a glimpse view or like a glance at the patient as a whole. So these are his hands, and these are his legs. And there is some whitenish here. Whitenish, it's not clear, but there are some glistening whitenish areas here and here. So collectively, is it a single diagnosis question or is it a list for differential? What do you think? Based on all these signs, do you think you should give the examiner a single diagnosis or a list of differential diagnoses? So a single diagnosis, exactly. Because we have some collectively, we can reach to a diagnosis, okay? So what's the diagnosis? Yeah. So I don't know if the Dr. Verma would agree because Graves' disease, we usually don't say this. I think it's old term. Yeah. We usually say thyroid eye disease, but with systemic manifestation, Yeah. Okay. So yeah, exactly. So this is a case of thyroid patient. What's interesting about this is that we don't have eyelid retraction of the upper eyelid. Okay, and if you remember, Dr. Verma in one of his classes said we usually in the exam they don't bring such cases because it's difficult. Because if we have like a peneurotic ptosis because of old age, because of the soft tissue involvement, the pathology, it might mask the proptosis per se. So if we have a ptosis, if we have an involutional or a peneurotic ptosis, it might mask the proptosis. Okay, so this is a difficult case because we don't have such manifest eyelid retraction and such evident proptosis because this patient is under treatment. So if you remember, sometimes thyroid patient underwent treatment or underwent surgery. So the manifest signs of eyelid retraction and proptosis are no longer evident, okay? But usually they don't bring such cases because these are difficult cases. The message of this slide or this case is what? Don't always expect female patient. So the first experience about thyroid eye disease, by the way. So don't always expect female patient. Yeah, it's more common in females, but this doesn't mean you may get a male patient with thyroid eye disease. Still, thyroid eye disease is the most common cause of proptosis in male gender. So don't be surprised if you have male patient, okay? Number two, how about the age? Let's see, Doctor. Have someone, Doctor? Are you ready? Can you answer? So what do you expect the age of this patient? To answer this question, what do you think is the expected age of this patient? Yeah, around 60. Okay, so maybe 60. Do you think thyroid eye disease, if we have a patient with like 60 or like 65, can we put thyroid eye disease among the causes for differential diagnosis? Generally speaking, we can say it's an old age, like an early old age. If we have a case of proptosis in a patient, like male patient 65 years old, can we list thyroid eye disease among the causes of proptosis in such age group? So imagine now you are in the oculoplastic station and you have a patient with bilateral proptosis, okay? And male patient, 65 years old. And you are going to give the examiner a list for differential diagnosis. Can you put the thyroid eye disease among the top, like number one? We have a bilateral proptosis in a male patient, 65 years old. Can we list thyroid?
Maybe not the first DD, not the first differential.
So what would be your first differential? Bilateral with eyelid retraction. Let's make it easier. Yeah, still we put the thyroid eye disease, okay? Because we have something called the bimodal pattern of the age of presentation. So we have the first pattern around 40 and the second pattern around 60, okay? So this is number one. We have such a bimodal pattern. Number two, you didn't take history. maybe the onset is many, many years before the date of their exam. So you don't know what was the onset of his condition, okay? So still you put thyroid eye disease in the differential diagnosis, okay? Even if you have an old patient, especially if you have a bilateral and other signs suggestive of thyroid eye disease. But I am with you. If we have a unilateral, you can put other things. Yeah, we can. If we have unilateral proptosis or we have dystopia, for example, so you may put thyroid at the bottom of your list. Okay.
Okay. Okay.
Thank you. And what's the name of this sign? Someone said pretibial myxedema. I think someone said it. Yeah. So you can say pretibial myxedema. And what is the sign of in this photo? Yeah.
Clapping.
Yeah, clapping may be an old term, but acropachy, as someone said. So again, the message, don't expect always a female gender. Don't expect like 40 years old in thyroid patient, maybe older, okay? Don't expect bilaterality. So thyroid is still one of the causes, the most common cause of unilateral proptosis, but axial proptosis. And don't always expect active like as the photos in Kanetsky, maybe because the patient is underwent treatment, medical treatment, or maybe surgical treatment, who knows, okay? And don't always expect the associated eyelid retraction. So as in this patient doesn't have eyelid retraction. And again, don't forget, maybe the signs are not only ocular, maybe there is some systemic signs. But generally, the examiner will give you a clue, okay? And here, maybe post-surgical status. So maybe the patient underwent orbital decompression or eye retraction surgery or strabismus surgery, okay? So definitely this will change the final signs, okay? Acropachy, and here pretibial myxedema. And here is the comment. So because this is an old book, it said Graves' disease. Okay, but usually, and you see clubbing. By the way, this is like in 80s, so 1985, something like this. So clubbing and Graves actually are old terms. I think so. And if you imagine, this photo actually was taken from the slide atlas for strabismus, because this patient has also a strabismus problem, but I'm not showing it right now. So this is a game. It's called the role play. And this is, again, about thyroid eye disease, because, again, the most common cause, most encountered case in oculoplastic station. And so it's taken from Dr. Gayatri experience in Amman this year. And let's play this game.
Yes, ma'am.
Okay, so I would like to ask you a personal question at first, okay?
Yes.
It's like semi-personal. So can you tell me your age? But don't say 1 second. So
yes.
the first lesson here is to listen carefully to the examiner. Don't rush to answer, especially if you know the answer, because of course you know the answer of your age. But try to listen until the examiner finishes, okay? So give me your age, but don't say it in years, okay? Say it in approximation in decades, okay? And try to be specific. Don't say just a decade. Try to add additional word to decade, so I can know your age in approximation. So once more, tell me your age in decades, but try to be specific. Yeah.
My age
is
I'm in my third decade, and reach my fourth decade in another 3 years.
Okay, 1 second. For me, you have spoken quickly, okay, and I got confused. Say it again.
I'm in my third decade now.
Okay,
and,
well, 1 second. 1 second. You said third decade, okay?
Yes, ma'am.
Third decade. I don't think so, Dr.
No.
I don't think so. I don't think you are in the third decade. So what's the meaning?
Which to which? Which number to which number? Third
Yeah.
decade is 20 to 30 or 30 to 40? Doctor?
Oh, sorry. 30 to 40.
Then which decade is that?
So we have another examiner intervened now. So thank you, Dr. Koshik. So Dr. Koshik, imagine now Dr. Koshik is the other examiner because you will have two examiners, okay? So Dr. Koshik now is helping you. I'm a malignant examiner and Dr. Koshik is a benign one. He's giving you a clue. So he's giving you a clue. Yeah.
I'm in my fourth decade.
Okay, so fourth decade.
Yes.
Okay. So fourth decade. So we have like early, mid, and late. Because fourth decade is about 10 years. It's like a long duration.
Yes, ma'am.
So you have to give me a more specific answer, like early, mid, late.
Late.
Okay. So this is your age.
Yes.
Thank you. So, but still unmute. So
yes,
this is an example of how sometimes you know the answer, but the way of the question itself is different. Is different from what you are accustomed to answer. So this is a kind of a test for your correlating information. Okay, and I know this decade is confusing. It's confusing topic. I just wanted to trick you, and luckily you feel the trick. Okay, so let's start by this role play. So can you please read aloud? This is like taken as it was written by Dr. Gayatri. So please read it aloud, but slowly, okay? Slowly. Yeah, read.
Lady with bilateral exophthalmos. I again followed same sequence of observation and explained what would I like to check on palpation and auscultation, as he asked only to tell but not to palpate. Then I asked, can I measure the proptosis? Examiner said yes, go ahead. I used hurtles and told correct measurements. Then discussion went on thyroid eye disease, sight-threatening conditions, management, UGOGO criteria, and Rundle's curve. I could answer confidently, and examiner was happy, said good.
Okay, so what do you think? This is a good experience, and it seems to us that the candidate was very confident answering these questions. She was well prepared and she passed her first attempt. The examiner was happy and she was happy, and we are happy for her. Okay, so first of all, she said lady.
Yes.
Okay, and so gender is important. Do you think gender is important in thyroid eye disease?
Yes, ma'am.
Why?
Because it is more common in females than in males, almost 5:1 ratio.
Okay, so do you know another significance of gender in thyroid eye disease?
Autoimmune, because of autoimmune.
And yeah, that's why it's much commoner in females. But how about male gender? So is there a link between gender and severity of thyroid eye disease?
Yes, ma'am. Smoking.
No, I'm talking about gender and severity.
Severity.
Yeah, more men smoke than women. Yeah, this is one factor, but male gender per se, some say that male gender is a risk factor for severity, okay? Male gender.
Yes, ma'am. Okay.
And she said bilateral. So this is important to mention the laterality, okay? Because when you are listing the differential, you have to, if you have a unilateral case, the list may be different from bilateral cases. And she said exophthalmos. Do you think exophthalmos is a good term here?
Exophthalmos is generally used for only thyroid eye disease. I think.
Yeah, because she already knows that the case is thyroid eye disease. That's why she said exophthalmos. But if you don't know the case is thyroid, you have to say proptosis. Okay, and it seems to us that she's have a sequence. Okay, so do you remember she is following a sequence? And if you remember the checklist or any checklist, whatever the source. The examination starts by what? What is the first step in examination? Observation or inspection, exactly. And she spoke verbally about the points to be assessed in palpation and auscultation, but without doing it on the patient, okay? So here you have to be careful and listen to the examiner instruction. Mostly if the examiner just say it, it means that there is no signs on palpation, there is no signs on auscultation. But in other scenarios, in other experiences, if the examiner asks you to palpate, you have to think carefully because generally there must be a sign. If the examiner asks you to palpate, mostly there will be a swelling or something positive, okay?
Yes.
And as you can see, she measured the proptosis by her tail. I'm asking you now, can you measure proptosis by her tail by yourself or not?
Yes, ma'am.
Okay, good. And she told correct measurements. And when you measure by her tail, doctor, so how many numbers do you provide the examiner? How many numbers?
2 numbers, ma'am. We have to compare both sides and see if that.
So just give me an example of proptosis bilateral by numbers.
On checking if it's bilateral and if it is more like 23 and 24, if it's more than 21, it will be bilateral proptosis.
No, don't say the normal or the abnormal. Just give me an example. Example of a proptosis bilateral.
23 millimeters and 24 millimeters.
Okay, so you give me 2 numbers, 23 and 20. Yeah, but actually you need to add more number. If you remember the first step when you are using her tail, what is the first step? What is the first step when you are using her tail? You do some adjustment.
The canthal distance, distance between the.
So you have to document and you have to show the examiner that you are aware of this, okay? And you have to. So what is the average number in general?
Sorry, ma'am, I don't recall.
Okay, so you don't recall, but you can think, okay? Let's see. So imagine now this is one eye, and this is the other eye, and this is the nose, okay?
Yes.
So you said the distance is between the lateral canthus, or we can say, we can say base diameter. So it's like the distance from here to here, right?
Yes.
From here, okay. So just imagine, what is the diameter of palpebral fissure? Here it's like 3 centimeters. 3 millimeters. Okay. So we have here 3 millimeters, and we have here 3 millimeters, and we have here like an additional eye 30 millimeters. So it's something around 90 millimeters. Okay.
Okay.
So this is to answer my question. So you have to give the examiner 3 numbers in order to show the examiner that you know everything, because you already know everything related to this case. And then she answered, solved the case quickly. So asked a lot of questions regarding thyroid and about the management, okay? And you have to know the lines of management. So what is, if we are asking you in general, what are you going to say to examiner like number 1 in the management? Like number 1 and number 2 in the management of thyroid eye disease patient?
For management?
Yeah.
You have to start from the history, ma'am.
Let's say we are talking here about treatment, okay? So treatment, you have a patient with thyroid eye disease, and the first line of treatment, you have like medications, you have surgical treatment, we have different lines.
Yes,
but we have like general simple lines. What is the lifestyle modification change is like very important. Okay, I will say it rapidly because we are running off our time. So first, how about smoking?
Yes, ma'am, to stop smoking.
Stop smoking. So don't forget to mention stop smoking. It's very simple, but sometimes the examiner wants to hear this answer. Stop smoking. Yes. How about control of thyroid eye disease? If the patient is hyperthyroidism, okay?
You have to refer to the internist to control the thyroid levels.
Yeah, so this is like 2 important lines of management. Many unfortunately forget to mention, and they are very important, because in order to control the disease, you have to establish your thyroid state, okay?
Yes.
And you have to stop smoking, because smoking has like many detrimental effects, like many negative effects on the severity of thyroid and the prognosis to treatment, okay? So again, and she was asked about Yugogo criteria. I don't know if she was asked specifically about Yugogo criteria, or she by herself volunteered to answer this criteria. So do you know the Yugogo criteria?
Yes, ma'am. It is divided into 3 parts: mild, moderate to severe, and sight-threatening.
Okay, so it's all about grading what? Grading of the severity or grading of the activity of the thyroid? Is it grading of severity or grading of activity?
Activity, I think. It's grading of the activity.
But you just said we have mild and we have mild.
Severity, sorry.
Severity. So this, so it's a classification for grading of severity, not activity. Yes. Okay.
Yes.
And do you know the Rander's curve?
Yes, ma'am. The curve which it depicts the different stages of the thyroid, the active stage and the fibrotic stage.
Yeah. Thank you, Doctor. So there is Yugogo criteria, and as you can see here, it's not only grading of severity. So we have mild, moderate to severe, and we have sight-threatening. But also, so interestingly, so Yugogo criteria actually for Graves, so the term you used. And Dr. Verma said also in this meeting that we can call it orbitopathy. So Yugogo for European group of Graves orbitopathy. This means that you can say Graves. Okay. So we have mild, moderate to severe, and sight-threatening. It's not only grading, but also it shows the urgency. So for example, in sight-threatening, this is warrants immediate intervention, okay? For example, in mild, there is no need for immune suppressive. So it gives you some guidelines for the management. And if you remember, we said before that if we have a symmetry of proptosis of 2 millimeter or more than 20 millimeters, so this is for diagnosis proptosis, and we have a grading. So we have grading based on Yugogo criteria. So if we have like exophthalmos more than 3 millimeters, this is considered one of the criteria for moderate to severe. So that's why we have 3 millimeter here on this slide. And we have also grading for eyelid retraction. And sometimes it's not only about the absolute number of the proptosis or the asymmetry. It's also about the change over time. Okay, so it's really important to document. So if we have a document of a progressive proptosis over time, this is an important sign also. So again, in mild, it is insufficient to justify immunosuppressive or surgical intervention. In moderate, we can prescribe immunosuppressive, and in sight-threatening, it warrants immediate intervention. This slide, it was taken from Iowa's website, so you can just Google it, like write down thyroid eye disease, Iowa. You will easily get this article. It's well written, and this graph about Randall's curve. So as you can see here, it shows what? So it's just a representation of the thyroid eye disease activity over time. So as you can see, with effective treatment, there is first stage it's called active phase. So we have an active phase and then stable phase. Okay, generally speaking, this is a natural course for thyroid eye disease. We have active phase at first and then stable phase. If you study, you will know a lot other variations like relapse, recurrence, and so on. So generally speaking, we have active phase and then a stable phase. Usually the active phase takes about 1 to 3 years. And as you can see, with effective treatment in this curve, okay, the patient will enter the stable phase earlier, okay, with less complication. So the outcome here is better because the curve here, which this V-axis represents the disease severity. So here, with effective treatment, like early treatment, proper treatment, the patient will enter the stable phase earlier. Okay, this is number one, and with less sequela or less complication. So the severity is less. But without treatment, like the upper graph here, untreated patient or improper treatment, the active phase lasts longer. and we may expect more complications, and the severity is more, like we will get like severe cases. And we may need emergency decompression, for example, or emergency eyelid surgery because of the sight-threatening complications that we mentioned before, which are corneal exposure and optic nerve compression. All right. And it is said that we have a range for active phase from 1 to 3 years. So we can expect 3 years if the patient is a smoker. So once again, the Ronder's curve shows what early initiation of therapy is crucial in diminishing the final severity of disease manifestations, okay? Any corrective surgery for cosmesis, generally speaking, it should be after stabilizing of the condition. So when it comes to surgery, we have two types of surgery, like emergency surgery in active phase, if there is like signs suggestive of optic nerve compression or corneal exposure. So the surgeon may give a trial of like steroid at first, and if there is no response, they will do decompression or eyelid surgery to control the exposure keratopathy. So this is a kind of surgery, like emergency surgery during the active phase. But if later on, if the patient needs cosmesis, something for disfigurement, or like proptosis or eyelid retraction, something for cosmesis, the corrective surgery has to be done during the stable phase, okay? And again, you will find in this wonderful article, like the clinical picture of active phase, so have active phase, and the clinical picture of stable phase. So as you can see, you may get cases in the exam, something in between, like active phase under treatment, or you may get stable phase. Of course, a stable phase is more difficult than active phase to diagnose in the exam, all right? So of course, you can expect during the active phase, there is a signs of inflammation, conjunctival injection, swelling, okay, chemosis, and you know, the activity in thyroid eye disease waxes and wanes. And as I said before, it usually stay active for 1 to 3 years and then becomes stable. So actually, thyroid eye disease is a self-limiting disease. Okay, it's something that will burn out eventually. It's something like, you know, ROP. Yeah, if you leave it, it will burn out. It will enter an inactive phase or stable phase. But what's important here is if you leave it without treatment or improper treatment, you will get a lot of complications. You may end up with blind eye, whether here in thyroid eye disease or in ROP. And both actually required what? Required early, prompt, effective treatment. All right? Early initiation of therapy is crucial in diminishing the final severity of disease manifestations. It's shown in Ronder's curve. Of course, these are results of studies, okay? And treatment initiated during the early months of active inflammatory phase has been shown to be the most effective. And initiation of therapy during the final months of active inflammatory phase has little effect on the final outcome of disease. This line shows the importance of time management, like early interference, early diagnosis and treatment. Because if you initiate the therapy during the final months of active inflammatory phase, it will have a little effect on the final outcome. All right, once the chronic fibrotic stage has set in, treatment options become more limited, like mainly for cosmesis, as I said before, primarily surgical. So this UGOGO criteria is just one kind of classification. As I said, according to severity, there are other classifications. We have something called VISA analysis. So VISA is like VISA, so V for vision, I for inflammation, S for strabismus, and A for appearance. And you will find it in the same article. And we have like all the classification like NUSPECS that I mentioned in my exam, but it was a while ago. And we have classification for the activity, something called clinical activity score for grading of the activity of the thyroid eye disease. Okay, let's check another experience, but actually this is one from Viva. And actually it's my own experience. It's a bit old, but it's still relevant. So, Doti, can you please unmute yourself and read this experience?
Second examiner, ophthalmic medicine. First examiner.
Okay, so this is station. So notice this is in a ophthalmic medicine station, not in other station, okay? Yeah, so first examiner shows me a picture of, yeah, read please, unilateral, say it.
Shows me a picture of unilateral proptosis in a middle-aged woman. Then he asked about the thyroid. Do you know a classification?
Okay, so 1 second.
I said,
so, yeah, 1 second. So see how is classification is important. So you need to read everything about classification. Do you know any classification?
Uggo classification.
Okay, but I think it's not enough to say it. You have to know additional information, like as doctor, we have mild, moderate to severe, and we have sight-threatening. Okay, okay. So
okay.
Since the thyroid is important, so thyroid is important not only in oculoplastic station, but in general medicine station. So, and we have thyroid emergency, like thyroid storm. Okay, so you have to know like general headlines about the lines of management, like the anti-thyroid drugs and so on. And he asked me about the treatment, okay? Again, this is the importance of grading the severity. So if it is a mild, if you have a mild thyroid eye disease, what is the mainstay treatment here?
Yes. It's usually the conservative methods like head end elevation, giving lubricants. Selenium can be given 100 microns twice a day. And the patient is asked to stop smoking and control of the thyroid status.
In collaboration
also,
with?
In collaboration with the endocrinologist or the internist.
Okay. And then the examiner was asking about steroid use. So whenever we have steroids, you have to know the indication, precautions, side effects, everything about the steroid workup. And he asked specifically about an immunosuppressive drug. Do you know immunosuppressive drugs that can be used in thyroid eye disease?
Azathioprine can be used.
Okay. So again, and he asked about orbital decompression. So although the station is in medicine, okay, it's general medicine, but all the questions related to ophthalmology, okay? So you have to be prepared. So after reading this experience, you have to be aware about everything about thyroid eye disease, okay, ophthalmologically, and you have to know about all the general information about thyroid disease in general, as you were in a medical school, okay? And if you see here, back then we have, so when I appeared to the exam, there wasn't Uggo criteria there. So I said no specs classification, and we have also another classification was called Morse classification. So I said these classifications, and don't ignore tear substitutes and lubricants, exactly as you said. Don't forget these lines of treatment. They are simple, but they are important. And smoking cessation, also very important, and control of the thyroid state. And don't forget collaboration with the endocrinologist or the physicians, whatever. Okay, this is another point that previously I thought that compressive optic neuropathy because of only enlargement of the extraocular muscles. Okay, so if I'm asking you now, what is the cause of compressive optic neuropathy? Mostly you will say because of the enlargement of the surrounding extraocular muscles. Okay, this is one reason. So as you can see in this coronal CT, we have huge enlargement of the extraocular muscles, mostly the inferior rectus, okay, muscle. But we have an additional reason for compressive optic neuropathy. Do you know what is this reason? And here is in the axial view, you can see in the axial view, we only appreciate medial rectus and lateral rectus in the axial view, but in coronal, we can have an overview about all the muscles. So it's not only enlargement of extraocular muscles, because the pathology also involves the fatty tissue, the adipose tissue. So enlargement and inflammation of adipose tissue and adipose tissue hypertrophy also an additional cause for compressive optic neuropathy. And that's why there is a kind of of orbital decompression. We have a surgery called orbital decompression, where the surgeon only remove fat, okay? So we have two pathologies for compressive optic neuropathy: extraocular muscle enlargements and hypertrophy of the fat. This photo again is from the slide atlas, this old book, but as you can see here, again, the importance of profile view. And if you remember Nafziger view and Worm's view, if we have a mild proptosis, especially if there is no associated lid retraction, it's very difficult to appreciate the presence of proptosis. But in profile view, or if we have Nafziger or exophthalmometer, we can document the presence of proptosis. Okay, let's see this ophthalmic teasers. And okay, so I'm asking you all to unmute your mics. Okay, as long you are sitting in a quiet environment, so you can please unmute your mics, please. It's a game. It's a competition. It's going to be bizarre, I know. So I'm going to show you now a photo, and you have to tell me what this photo shows. Ready?
Yes.
Steady. Go. So let's see who will answer this first.
Enlarged extraocular muscle.
Who is that soft, quiet voice? Who is talking?
Inflamed muscle, yeah.
Enlarged extraocular muscle.
He won. Okay, so because he answered like slowly and confidently, and I think someone answered before him, but I heard him. This is the first time to answer slowly, Doctor. So this is an enlargement of extraocular muscles. Again, it's related to thyroid eye disease. This is from autopsy. And what is very characteristic of, what is unique about the extraocular muscle enlargement of thyroid eye disease?
Sparing the tendon.
Sparing the tendon. So, okay. So we have yeah, exactly. So we have, thank you, Doctor. So we have a fusiform enlargement of the muscle belly, the muscle body itself, but we have a sparing of the tendon, and this is very characteristic of thyroid eye disease enlargement of the extraocular muscles, okay? So what are the other causes of enlargement of extraocular muscles? What are the other causes of enlargement of extraocular muscles other than thyroid eye disease?
Orbital myositis.
So yeah, orbital. So number 2 is orbital myositis. So orbital myositis, it involves also the tendon. Okay. Do you know another cause related to proptosis? So it's proptosis and enlargement of extraocular muscles. Because here, actually, the question is about enlargement of extraocular muscles in a case of proptosis. So we have number 1. Yeah.
Idiopathic inflammatory orbital disease.
You can say it's belong to myositis. So number 1 is thyroid eye disease. Number 2, inflammatory, as Dr. said, idiopathic inflammatory. So you have, we can here write myositis. And I need another one.
Carotid cavernous fistula.
So yeah, carotid cavernous fistula. Okay, high flow carotid cavernous fistula, yeah, can cause enlargement of extraocular muscle. Thank you. Okay. In this slide, I'm just stressing again about the importance of cessation of smoking. And actually, I was asked in my Viva in general medicine station about the effect of smoking on the eye in general. So you have to prepare this question, okay? The effect of smoking, cigarette smoking on the eye. So by the way, I was tricking you here because in literature, you may find promotion of smoking. It's an incomplete sentence, but actually the full sentence is promotion of smoking cessation, but it's generally confusing. You can just say smoking cessation, okay? Or stop smoking.
Yes, madam.
Okay. So let's read this experience aloud. Yeah, go ahead.
All right. Or second case, old male with severe left-sided non-axial proptosis. Okay, examine the case. Old male with severe left-sided non-axial proptosis. I said there is an axial proptosis. He said, how do you know that it is axial? I said by measurement. And so I measured and I found that it is non-axial. I did a systematic examination of a case of proptosis. discussion went on about the differential diagnosis of such a case, I did one mistake, that I was thinking silently in my mind about the possible causes. Then the examiner said, "What are the causes of proptosis?" And then I said, "So please don't pause. If you're going to think loudly and say something." At the end, I said, "I have to exclude lymphoma."
Okay, thank you. I admire your way of your speaking. You are as if it is a story. So I like your intonation. Actually, this is my experience. Yeah, so first I was rushed at saying this is an axial proptosis, but then I did the measurement by a ruler, then discovered that this is actually a case of this non-axial proptosis. So here, very important to decide whether it is axial or non-axial, because it helps you in listing the differential diagnosis. So generally speaking, we don't list thyroid among non-axial. Thyroid generally in axial proptosis, causing axial proptosis. And don't forget the side and the severity. And actually, I did the measurement by load, okay? So I already have a load exophthalmometer, so I did the measurement by load, and I have a ruler to document the measurement of dystopia, okay? So after reading this experience, what shall you do? So this is like a small piece of information, okay? So you have in your study notes to be prepared by a list for the differential diagnosis for the causes of non-axial proptosis, okay? So what's the meaning of non-axial proptosis?
So when there is a non-axial proptosis, it means that the globe is pushed away from the either downwards, upwards, outwards, or inwards because of the mass lesion.
Okay, so we have dystopia.
And when it is, yes, there's a dystopia.
Okay, and you have to specify the direction of dystopia. Okay, actually, I wrote here vertical dystopia, but actually, I remember it was inferior dystopia because you need to say which direction. Because what is the importance of mentioning the direction in order to later on to list the causes? Because if it is inferior, you think of swelling at the upper orbit. If it is like temporal dystopia, you think of causes in the nasal orbit, like in the smodal sinus, for example. So you have to state the direction of dystopia in order to give the examiner a relevant causes. Okay? And here, right. So again, don't make this mistake, my mistake. Don't give the examiner a long pause. You have to list the causes. So in order to fill the gap, you may tell the examiner there is, for example, vascular cause, traumatic causes, inflammatory causes, and you have to mention like an example for each heading. And you may tell the examiner, I need to take history, ask about something. So don't give the examiner a long pause, think loudly until you give the examiner a good list of the facial diagnosis. So until now, I don't know if the case was due to lymphoma or not. But actually, in my station, I said only one cause, and this is wrong, because actually the examiner was waiting for a list of differential diagnoses, a list of causes. But because of the time, I said only one. Luckily, I passed, but it's not the ideal answer, because the case didn't show a pathognomonic sign of lymphoma. So it's like a vague case. Since it is a vague case, not clear case, you have to give at least 3 causes that matches the keywords here, like non-axial proptosis, unilateral proptosis. Just give me a comment on this photo.
In this color photograph, I can see that there is dystopia in the right eye, and there is a fullness in the superior orbital area in the right eye, and the corneal reflex is decentered superiorly. So in this case, I see this is a non-axial proptosis or a dystopia in downward direction.
Okay, excellent. But the case in my station wasn't like this. The patient didn't have a swelling. But here I brought a photo from Kanetsky to show a case of lymphoma. Okay, so if we have a dystopia, usually there is a swelling. So actually there is a swelling here, okay? We have a swelling here. And if you imagine and draw the palpebral fissure, you see the palpebral fissure is here. This is a clue a clue for dystopia. So just imagine in your head or your mind the palpebral fissure. So here is the position of normal fissure, and here the fissure is displaced down because of the displacement of the globe down. Okay? If I ask you right now, if you test the up gaze, what do you expect the up gaze movement?
The up gaze will be restricted in comparison to the left eye because of possible mass lesion in superior orbital area.
Exactly. So usually you will find all these signs combined. If you have a mass in one area, like big enough, will push the globe to the opposite direction. So we have upper swelling, pushes the globe down, inferior dystopia, and we expect limitation of the movement in up gaze. Okay. Do you think this patient has diplopia or not?
Yes, he should have diplopia because yes, I expect a diplopia in this patient. He will, because the pupillary area.
Yeah, because this eye is as if it is looking down. The visual axis is definitely not aligned with that one. And the Hirschberg is decentered. So Hirschberg is decentered. Actually, it's complicated because of secondary squint. Actually, when we have a significant dystopia, if we have a huge mass pushing the globe to one direction, so the visual axis is no longer in normal relationship with the other eye. So there will be a secondary strabismus. Okay, and this is an adult patient, so the patient may experience diplopia. Okay, well done.
Yes.
And here I'm showing you that actually you have to check for the preorbital area because sometimes we have lymphomas here. Okay, so do you know the name of this sign?
Yeah. Salmon patch appearance.
Say it again.
It's a salmon patch appearance.
Yes.
I mean, it's like a
exactly.
Lymphoma.
Yeah. But by the way, the L is silent. Like it's salmon. Okay.
It's salmon.
And you can check also the lacrimal gland area because the lymphoma can affect the lacrimal gland. Okay. So if you remember, among the checklist of orbit proptosis evaluation is to check the preocular area here, the conjunctiva. Thank you, Dr. Well done. So what can help you to set the differential diagnosis? You can use some mnemonics, but of course you don't say mnemonics in the exam, but in your mind, you can use the Professor Motto mnemonics, like vitamin C, like V for vascular, I for infection, T for trauma, A for autoimmune, M for metabolic, or something like this, and idiopathic, congenital, neoplastic, things like that. But it's not enough to say, so if you say to the examiner, we have vascular causes for proptosis, and so you stopped, this is like a zero answer, next to zero answer. You have to give the examiner an example. So vascular lesions such as varices, arteriovenous malformation, we have congenital causes like dermoid. So you have to say the heading and an example under each heading. And you can use this as in CyberSight lecture, he used a 1010. This is a cartoon character to memorize the causes, like T for thyroid, I for inflammation, N for neoplasm, and then T for trauma, I for infection, and N for congenital for newborn. Or you can classify the cause according, because we have like 3 basic spaces in the orbit that can cause proptosis. We have intraconal, we have extraconal, we have subpreosteal, like subpreosteal hematoma or abscess. So according to the space, you can divide according to the space. What I said is according to the space, or maybe according to the structure, like optic nerve tumors or something, extraocular muscles mass, according to the structure involved. Maybe you have to do a lot of list of differential diagnosis based on the age, maybe based on the signs, whether they are painful or painless, whether they are unilateral or bilateral, whether they are axial or non-axial. And if we have dystopia, according to dystopia, you have to list the causes for inferior dystopia, make a list for causes of superior dystopia, make a list for cause of nasal dystopia, and so on. So you have to do your own notes. Okay, don't only give an examiner a blind list of causes of proptosis or a blind list for cause of dystopia, you have to tailor and give the examiner a list of relevant causes for each case, according to the case, according to the photo if you are in the Viva. Okay, I forgot to mention in this slide that we have like 3 main points here. Look, number 1, in the exam to decide whether it's pseudo proptosis or true proptosis, and it might be 2 elements in one case. And then you have to decide whether it's axial or non-axial. Simply, axial proptosis is just forward protrusion of the globe, as we said before in previous classes. But non-axial proptosis is actually a proptosis combined with dystopia. So we have like forward displacement of the globe, this is proptosis, and also displacement either vertically or horizontally. And number 3, the third point to be considered is to have a list for differential diagnosis, a relevant list, and be aware sometimes the case has, like, as I said before, pathognomonic signs, and actually the examiner is waiting for a single answer diagnosis. Okay, Dr. Ritesh, are you here? Do you have any comment?
Yeah, I'm here.
You are here by your heart, I know, but do you have any comment?
Yeah, so what do you want?
Yeah, go ahead.
Okay, so let me just take 2 minutes
Okay,
because
okay.
the new UGO guidelines that have come are there's a massive change in the treatment of thyroid eye disease. From my clinics, whenever I see a patient of thyroid eye disease, for me, I have to classify first whether it's a sight threatening or not sight threatening. So, first thing I ask uh, from my residents is to check for the color vision, the ocular motility, and to see if there is any exposure keratopathy. So, if the patient has a significant loss of vision, defective color vision, and there is exposure, there is significant exposure, then I think in terms of surgery, whether it is active or inactive. Because whenever it is a sight threatening disease, then you have to go full guns blazing. So I start with 3 doses of high dose methylprednisolone. And then if the patient is not improving on the 3rd or 4th day, then immediate decompression surgery. So this is one line of treatment when the patient has a sight-threatening disease in your clinic on presentation. And the second is if the patient does not have a sight-threatening disease, he has mild, moderate, or severe disease depending upon the amount of restriction of ocular motility, diplopia, and the other soft tissue signs. So then, if the patient has a mild disease, it is a non-progressive. I have seen the patient 3 or 4 months down the line, he's non-progressive. Then observation and then only mild steroids orally you can give. Otherwise, if the patient is progressing, that is depending upon the clinical activity score. So it is a good idea to read clinical activity score for the exam as well as in your clinics because it is very easy to remember. You don't have to fill a large form for that. And when you are sure that there is no activity, then you can simply observe. And on follow-ups, if you feel the patient progressing, then you start on 500 milligrams of IV methylpred every week for 6 weeks, which has these are the guidelines given by UGOGO, and you can go up to a total accumulative dose of 8 grams. And with this, if the patient is non-responding or is steroid dependent or he is diabetic or hypertensive that you have to limit your steroids, then you can add on mycophenolate. So mycophenolate mofetil is now the first line of immunosuppressants that we give. And if the patient is still progressing, then you think of cyclosporin and azathioprine.
What is the first drug?
It is mycophenolate mofetil,
MMFP. Okay.
And the second line of drugs are now azathioprine and cyclosporin. And there's a new drug which is a hot topic in thyroid eye disease is trepotumumab. It is by the name of Tepeza. There are a lot of studies and it has been published in New England Journal of Medicine, and it's worthy of any GM because it has shown you don't require anything and it can reverse the proptosis also. So trepotumumab is something you should mention in your final verdict. I mean, it will give you some extra sort of marks. So this is the general guideline of treatment of thyroid eye disease.
Okay, thank you, Dr. Verma. Thank you so much. Before I read aloud this past experience, again, it's mine. Remember, the first experience was about thyroid eye disease, okay, where the patient has like pathognomonic signs, and the discussion is all about thyroid eye disease as a cause of proptosis and management of thyroid eye disease and other follow-up questions related to thyroid eye disease. Number 2 experience I shared with you is about my case where I said only lymphoma, although the case is a bit vague, like it's kind of non-axial proptosis. So I should have said what a list of differential diagnosis. Okay. Number 3 experience, I will read it now. So it was actually my first case in the oculoplastic station. So the examiner gave me a scenario about the patient in front of me. It was a female patient, it was a lady. And the examiner said she has watery eye. Okay. So actually, to be honest, I wasn't attentive to this key word. Like this, actually, it was a clue. He gave me a clue, watery eye. At first, I observed the case. This is like number 1 in examination. And I thought, so this is my experience. I thought there was a proptosis on the left side. Since I already had my Lute exophthalmometer, I did the measurement quickly, and I realized that it was like pseudo appearance, nothing at all. There was no any proptosis. I think the examiner repeated his clue and said she has watery eye. And he said, actually, he was like an angel. I still remember him. He said, look closer to the patient. And then I saw, you know, on that side, like enlarged lower punctum. So she must be underwent punctoplasty. So I said she underwent punctoplasty. Again, I missed another sign. He said, is there any scar or something? Then I realized that there is like a faint, I said this experience before, but because it's important, I'm repeating it again. So I found a DCR scar on the left side. So actually the case was what? It was a case post-DCR, like external DCR. Okay, and you know, one of the steps of DCR, you have to have intubation. Sometimes that, you know, the tube was too tight and it caused something called cheese wiring of the punctum. So actually the punctum, the lower punctum was enlarged because of the previous complication of cheese wiring. But at the time of the exam, there was no any tube because, you know, we usually remove the tube after 6 months, So the case actually is a post-surgical status, definitely for acquired nasolacrimal duct obstruction. Then she underwent external DCR with intubation. Then the intubation resulted in cheese wiring of the punctum. And now they present the case to me post-surgery, like just the scar of the DCR, okay, and the cheese wired punctum. Okay, so I said external DCR. He asked about the type of DCRs. I said external. He said, did she had DCR on the right side? I said, since there is no scar, but she may have had like endoscopic DCR. So sometimes the patient underwent DCR, but endoscopic. Definitely in endoscopic DCR, you don't see any scar. And then he asked me about the steps of the external DCR, and he was focused on the first step. And he was waiting to hear my first sentence, which is adrenaline-soaked gas in the nose to control any bleeding and for hemostasis. And he asked me about the skin position and so on. Of course, you know, you have to know the steps. I think it's well written anywhere, and it's well written in Wong. Yeah, and I think DCR is one of the important surgery that you need to know about the steps. Okay, now your question, why I'm saying this experience, although we are now talking about proptosis, I brought this experience because I mistakenly said it was proptosis. So it's okay to like to have a, you know, incorrect or wrong start. Like it's not a problem. You have to, you know, be determined and don't lose hope. Even if you think there is like ptosis or proptosis, and then you have to do the measurement quickly in order to realize whether it's true or pseudo. And then, by the way, the examiner will feel that you are a good candidate, and he or she will help you, hopefully, and give you some additional clues. Okay, so actually, this experience is all about lacrimal system. But since the start was about proptosis, like pseudoproptosis, I brought this experience today. All right. The next experience. Okay. Again, I'm just brought the experience as it was written. So here the candidate said, unfortunately, the examiner said, here it should be said, not cited, so said only one word, examine, okay? Okay, for me, it seems to me that that candidate was surprised by one word instruction from the examiner. It seems to me that the candidate was surprised by one word instruction given by the examiner, since the examiner said only examine. Actually, this is a common scenario. So don't be surprised. Don't be ever surprised that the examiner will say examine. Okay, because this is like an examination station. So you have to examine. Okay. And then according to your start and your way of examination and observation, and the examiner definitely will say something later on. Anyhow, so don't be surprised if the examiner said only one word at the beginning and said, examine the case. Okay, let's continue. So he was a patient. Okay, so the candidate here didn't mention the gender, but anyhow, he was a patient with apparent proptosis. Okay, see, the candidate noticed proptosis. There is red eye, and this is an important sign. Okay, because whenever you come across a red eye, there must be an explanation, okay? So you have to solve this puzzle or this sign. You have to search for the cause of redness, okay? First, you have to decide whether it is red or not. And once it is red, there must be a cause for such redness. And definitely the examiner will ask you why this eye is red, okay? Because redness is an important sign. And in our clinical practice, we have some dangerous causes for redness, and sometimes such cases need urgent interference, okay? Anyhow, so we have proptosis, red eye. So proptosis is an important sign, red eye is an important sign. And then exotropia, okay? So exotropia in the primary position. And here's a candidate said without abnormal head posture. And again, the candidate said no heterochromia or anisocoria. All right. He said, I'll start to measure the proptosis. And the examiner allowed him to do it. So did it. And I measured it, and it was like 22 millimeters in one eye and 25 in the other eye. Okay, so he gave the examiner 2 readings. And as I said before, you have to provide also the base diameter, the distance between the lateral canthi, okay? All right. And how to manage according to corneal affection by dryness, and here optic nerve affection by compression. So I think according to this scenario, although we have like incomplete information, it seems to us that this is a case of thyroid eye disease, okay? Because once there is optic nerve pressure and the cornea, this is like a reminder of what? Of sight-threatening complication of thyroid eye disease, okay? So this is what I was trying to tell you before, that try to have like some reflection about the experience. So although the experience here is not elaborate, it's not complete, but since the question here is about optic nerve and, corneal affection, usually this is about what? Sight-threatening complication in thyroid eye disease. So I guess it was a case of thyroid eye disease, okay? And there might be affection of the cornea, and that's why there is redness of the eye. Remember, any cause of proptosis can lead to red eye. Any cause of proptosis can lead to red eye if it causes what? Exposure keratopathy, okay? So even if you have like optic nerve glioma, okay? Optic nerve glioma is one of the cause of proptosis, but without redness, okay? There is no redness. But imagine now the proptosis is severe enough to cause exposure and the cornea become exposed with ulceration. So now the eye becomes red. So this is a general rule. Any cause of proptosis can cause redness because of corneal exposure. And that's why for any case of proptosis, you have to be careful about examining the cornea. And if remember, this is one of the points to be assessed in the checklist we mentioned before. So here, it seems to me that the examiner was asking about what? If you remember the Google criteria, he was asking about the management of the sight-threatening thyroid eye disease. According to classification, we have mild, this is number 1, and we have moderate to severe thyroid eye disease, and we have sight-threatening. So here, the examiner is focusing on the sight-threatening complications. And if there is optic nerve affection, how to treat? Okay, so here is the candidate said, I refer to oculoplastic surgeon for decompression. All right, so I refer is good. To work in collaboration with a specialist, this is good answer, good start. And then you need to mention the line of treatment. Actually, if you study, of course, you know better than me that there is a trial of medical treatment by steroids at first. And if it fails, okay, the patient should undergo decompression. So decompression is not number 1 in optic nerve affection. So if you have signs suggestive of optic nerve, progressive optic nerve, we have a trial of medical treatment at first. And if it fails, okay, the second step is urgent orbital decompression. And again, you will find it in that article. So here the examiner asked the candidate, what do you think is the complaint of the patient? So remember, I said before, you have to know a little bit about the symptoms, okay? Symptoms, not only the signs, but also the symptoms. So what do you think is the complaint of the patient? The candidate said cosmetically in acceptance, maybe because of proptosis. The examiner, once the examiner said what else, it means that he needs more answers or additional points. So the candidate kept silence, okay. What do you think? So here the examiner, I guess he was giving him a clue. So what do you think is the vision of the patient? This means that the examiner is helping the candidate. Actually was giving him a clue that the symptom is vision related, okay? So again, remember, what was the question at first? What do you think is the complaint of the patient, okay? The candidate said something related to cosmesis, but here the examiner was giving him a clue about the vision. So the complaint must be related to vision. And if you remember, when we mentioned the symptoms of thyroid eye disease, what are the possible symptoms? When it comes to vision, we have either blurring of vision or diminution of vision, or what? Diplopia. So let's see the answer of the candidate. Yeah, the candidate finally said diplopic, and actually the examiner was waiting for this answer, and he said yes. Okay, he insisted to hear this word. Okay, and again, it seems to me that the candidate was surprised by this question. But again, the patient has diplopia. Maybe it's something related to the exotropia that he noticed at first. Although the exotropia is not the most common pattern of strabismus in thyroid eye disease. But anyhow, the message here is don't forget about diplopia, one of the visual symptoms in a case of proptosis. In proptosis in general, not only thyroid eye disease, but diplopia is one of the visual symptoms in proptosis, especially if it is associated with dystopia. All right? Okay. Here added some question mark. Whenever you face across squint, you have to comment on the motility, okay? But the candidate didn't mention anything about the motility. It's really important. There is some redness, but I guess there might be an affection of the cornea. And again, if there is an affection of the cornea, additional complaints could be like pain or discomfort, something like this. Okay, and here he mentioned dryness, okay? So don't forget lubrication, as we said before. So I'm repeating now this slide. I said it before in the previous class. Again, visual symptoms, blurring of vision, this is number 1, or diplopia, okay? Especially if we have dystopia. So dystopia, if it is significant enough, can result in secondary squint and result in diplopia. So dystopia, so this is a kind of mnemonic. So dystopia, remember diplopia, okay? The next experience, it was last year in Mumbai, a patient with left globe displaced inferiorly. So generally it means inferior dystopia. I was asked to examine. So again, this is a common scenario. The examiner will say only examine. I palpated the orbital rim. Here, as you can see, the examiner allowed the candidate to do palpation. Sometimes the examiner will say, just say it without palpation or without touching the patient, or sometimes the examiner will allow you to palpate and do everything. And he asked for retropulsion. Here the candidate, was taking permission to do retropulsion. The examiner allowed him, and he found resistant to retropulsion. Generally speaking, most of the cases has positive retropulsion. And it seems to me, since it is a unilateral case, it will be very easy to compare it with the normal side. In modality, there was severe, so here severe, not severe restriction of up gaze. Okay, so we have if you remember, if we have dystopia, so here you find that the signs are helping each other. What's the meaning of helping each other? So here, when the globe is displaced inferiorly, it means there is some swelling, some mass in the upper orbit, okay, pushing the globe inferiorly. And, it's like a space-occupying lesion in the orbit superiorly, pushing the globe inferiorly. So you can expect what regarding the up gaze will be limited. So here the sign, so the motility effect here, the motility finding here matches or seemed logical with the inferior dystopia, okay? And again, it seems that the case also has proptosis. So he asked the candidate to do measurement. Okay, the candidate asked for hortail, but there wasn't any hortail. So he did the measurement by ruler, okay? Here, the candidate said, surprisingly, there was no proptosis. I don't know why the candidate was surprised, because we said before, sometimes we have cases with only dystopia, okay? Sometimes we have cases with axial proptosis, just proptosis, forward protrusion. And sometimes we have cases with proptosis and dystopia. And the other name for such a case is non-axial proptosis. So we have 3 scenarios. So it's not rare, okay, to have a case of dystopia without proptosis. And actually this means that the mass is somehow anterior, just pushing the globe from above, but actually it is not big enough to push the globe forward. And then since the case is inferior dystopia, the examiner asked him to do the measurement, to give him the actual measurement. We discussed this before, how to do measurement for dystopia. All right. And I guess the follow-up question will be about what are the differential diagnoses of inferior dystopia. So the candidate must provide the examiner with a list of relevant causes for inferior dystopia. Okay, so this scenario or this experience is all about what inferior dystopia differential diagnosis. Okay, so I brought here a photo that one of you posted before about it seems to me that it's similar to the previous scenario. We have inferior dystopia here. And if you remember how we measure the inferior dystopia, like vertical dystopia, first we have to comment on the Hirschberg test. So I'll repeat it quickly. So the Hirschberg is not evident here, but I can see the reflection central here and central here. So the Hirschberg is central. So this is number 1. And this means what? This means that the visual axes are aligned, okay? The globe is just displaced inferiorly, but the fusional reserve, the vertical fusional reserves keeps the visual axis somehow aligned with the other eye. So then we draw the line, this corner reflection, exactly horizontal line, okay? And then we draw a vertical line. So I'm talking now drawing, but actually in the exam you must have 2 rulers, one horizontal ruler to be like this yellow line, and the vertical ruler like the red line, and measure the amount of displacement, the distance from here to here, okay? I said this before in detail in a previous class when we were talking about dystopia measurements, okay? So this is actually inferior dystopia. So we have 3 clues here. The first clue is we have if you imagine the palpebral fissure is displaced here inferiorly, as I said before, okay? Here the palpebral fissure is here. Here the palpebral fissure is like down here. Everything is shifted because of the displacement of the globe inferiorly. Okay, and this is like number one. This is a clue, even without measurement, just from the appearance at glance. Second, we have fullness here, something here, full the superior sulcus. So this supports our sign of this spherodystopia. There's something here is pushing the globe inferiorly. Okay. Number three is motility. So if you test them up gaze, then you will find limitation of the up gaze because of the space occupying lesion in this area in the upper orbit. Okay, so if you comment at first, you will this like very easy clues that we have, like the palpebral fissure, the canthi is displaced down. We have fullness here and the limitation of motility in up gaze. Okay, and then you will do the measurement by the ruler and you will mention to the examiner the exact amount of dystopia in millimeters. All right. This is from another candidate experience, unilateral proptosis with inferior dystopia. So here, actually, it was just one line experience, but it shows us that you might get a case of proptosis with dystopia. Okay. And again, the discussion went on diplopia. So although the case is like oculoplastics, proptosis, dystopia, but sometimes, as I said before, many times there is a close intimacy or relationship between strabismus and oculoplasty. So because of the secondary squint, the patient may complain of diplopia. Okay, so how we will manage diplopia? Okay, first you have to search for the cause of the proptosis and dystopia because it might be a dangerous cause, and you have to first tag the primary pathology, the primary cause, which is the cause of proptosis and inferior dystopia. And regarding diplopia, to make a relief of diplopia, you may make a patch, like, general line of management of diplopia, you may patch this eye. Okay, this is for temporary relief. If we have like small amount of diplopia, you may prescribe, relieving prisms, where the prism base is against the deviation. Okay, and you may consider strabismus surgery, but as you know, strabismus surgery should be done after correction of any thing related to the orbit. So you have to correct the cause of proptosis or dystopia first, and then think about muscle surgery, extraocular muscle surgery. Here, since the case is a bit vague, just proptosis and inferior dystopia, here this is a not single answer or single diagnosis case, it's a list of differential diagnosis. Okay, I got this message before from a candidate who passed the exam first attempt, but you will see that he didn't answer all the questions. So don't lose hope. Even if you didn't answer all the questions, still you can pass the exam because they will evaluate you according to your overall performance. You will have 2 cases, sometimes 3 cases, okay? Even if you don't answer some of the questions, as long as they are not important questions, still you can manage and you can pass the exam. So here's the candidate, by his own words, he said, he was asking me, by the way, in the clinical exam, I had a case of inferior displacement of the left globe. Again, inferior dystopia, okay? And I was asked if I expect him to have diplopia. Unfortunately, the candidate said no. Okay. I'm not sure. I'm thinking about it since then. Okay. So actually, the answer should be yes. And, from the way of the question, you can expect a yes answer. And the examiner said, do you expect the patient has diplopia? It seems to me that the answer should be yes, even if you don't know the exact answer. This is a way of question that the answer should be yes. But imagine now, if you said yes, you have to give the examiner explanation, okay? In orbital disorders that cause proptosis, dystopia, you may get diplopia. Because the orbital disorder or orbital mass or orbital pathology can affect the muscles itself, the motility itself, by different mechanisms. For example, in thyroid eye disease, let's give you some examples. In thyroid eye disease, in the active phase, there is inflammation and swelling, and later on, the fibrosis. So this is definitely will affect the function of the muscle. Okay, this is number one mechanism. Number two, maybe the orbital disorder affects the nerves. Okay, like in orbital apex syndrome, we have proptosis and we have also paresis. So it might affect the nerves. This is another mechanism. Number three mechanism is space occupying lesion. If we have a mass like in the orbit, it might compress the muscle, interfere with the range of like the flexibility of the muscle. Okay, so it's a kind of restrictive. Like we can consider it as a restrictive. Okay, so if you imagine if mass compressing the muscle, definitely it affects its function. Okay, again, as I said before, if we have like significant dystopia, because dystopia is all about what? Is all about a mass. There is a mass pushing the globe to one direction. So it's a kind of space, like orbital space occupying lesion. Definitely it might interfere, if it is significant enough, it might interfere with the muscles motility. And it pushing the globe to one direction to a severe degree, you might expect that the visual axis is no longer in alliance with the other eye. Okay, here, as I said before, orbital apex syndrome is a kind of you may get affection of the motor nerves that supply the muscles. Okay, now I have a question for you right now. Suppose that the patient, patient has a significant dystopia, and as I said, the eye is displaced to a greater extent, and we have secondary squint, and the visual axis is no longer aligned with the other eye. So the patient must complain from what? Must complain from diplopia. But even though there is no diplopia, so I will repeat it again. What are the possible explanation of absence of diplopia despite the presence of, like, let's say, significant dystopia or acquired strabismus, for example, hypotropia and thyroid eye disease? So let's read the question once more. So imagine now you have a patient of significant dystopia, okay, or you have a patient with thyroid eye disease with hypotropia, because the most commonly affected muscle is inferior rectus, and we have hypotropia. And even though, despite the presence of this or this, the patient doesn't complain from diplopia. What could be the explanation for this? Actually, we have some possibilities. Okay, number one explanation, blind eye, or like the eye with hypotropia, for example, thyroid eye disease, actually is a non-seeing eye, or like we have like the patient has like very poor vision. So in such a case, there will be any complaint about diplopia. So this could be an explanation. Another explanation, let's say for significant dystopia in a child. If we have a child, so usually especially like young children, they don't complain from diplopia, okay, even if they have like acquired strabismus or acquired cause for strabismus, okay, so they don't complain from diplopia because they usually suppress immediately. So once they develop acquired strabismus, the brain will suppress the diplopic image. So this is another explanation. All right, in this slide again, so I guess in most experiences is most of them were about inferior dystopia. So inferior dystopia is the most encountered dystopia according to the past candid experience. Here is the title of this slide. I wrote hypotropia versus inferior dystopia. So be aware that there might be only hypotropia, just strabismus, okay, there as in this photo. Okay, by the way, the Hirschberg test here is central, although the Hirschberg, it's not always like a central dot. It could be like two dots according to the type of photography. So here we have two dots straddling the pupil. But here the reflection is not visible because it is on the sclera, above. So it's not visible. So here in such a case, we have only hypotropia, okay? In this photo, we have only inferior dystopia. So again, if you imagine, first, the Hirschberg test is central. So the visual axes are aligned despite the presence of proptosis and inferior dystopia. Here, in such a case, we have non-axial proptosis. Why non-axial? Because we have proptosis, and the globe also displays downward because of inferior dystopia. So if you draw the papillary fissure, it will be here. Everything is shifted, and there is fullness here. And if you test the up gaze, it will be limited for sure, okay? Hirschberg test, we don't have manifest squint here. There is no manifest squint in the primary position. So at the primary position, there is no manifest strabismus. Hirschberg is central. It's all about dystopia, inferior dystopia. So once more, here, this photo is only hypotropia. And by the way, this is from a reference, and this is after correction of the hypotropia by inferior rectus recession. And in this photo is only inferior dystopia. And in this photo, the last one in red frame, is actually inferior dystopia severe enough to cause also secondary squint. Okay, so the visual axis here is not definitely aligned with the other eye. So we have dystopia, everything is shifted down, and we have fullness here, and definitely the motility in up gaze is affected, okay? But we also have squint. But squint is not a big deal here. It's not important at all. The most important thing that you need to focus on is what the inferior dystopia and probably also the proptosis. So again, this is non-axial proptosis. So here, you know, we have like different scenarios. All right. The case may have what? Axial proptosis. So you may come across a case with axial proptosis alone, okay? Or you may come across a case with only dystopia. Or you may come across a case with proptosis and dystopia, and in such a case, we call it non-axial proptosis. Okay? Let's make it harder and more confusing. If we add what? Strabismus. Okay, so you may get a case of axial proptosis, but the visual axes are aligned without strabismus. Or sometimes you may get a case of axial proptosis with strabismus, and this is really confusing for many candidates, unfortunately. Okay, and you may get mild dystopia without strabismus, or it could be severe dystopia causing secondary strabismus, and you may get all in one, like cases with proptosis, with dystopia, and strabismus. Okay, and don't forget we have cases with only strabismus. I hope we can talk more about strabismus when the time comes to talk about strabismus classes. Anyhow, so in order to be confident and to be competent, you need to get exposed to all these scenarios. And that's why it's really important to have like an observership or to be attached to some specialty clinics, whether strabismus clinics or oculoplastic clinics, because 1, 2, 3, 4, 5, 6, we have like at least 6 scenarios. You can study and look for case records, reports, cases online, but nothing better than to witness the case by yourself and to see how it could be assessed, like in every situation. All right. But simply you can search for photos, like for each condition. Now the next part in this presentation is a quiz. I'm going to take the advantage of the presence of Dr. Verma to show you this interactive, hopefully interactive quiz. It's pseudo break because you are going to answer a number of quizzes. You will see a few slides, and there will be like a background music. I use the music as a distraction, okay, to make some distraction, yeah. And each question is timed. So you see this bar. Until the bar is reaching the end of the slide will be shifted, okay? And you will see a question, and I hope you have a like notebook to write the answer, okay? Please don't answer in the chat box, just answer in your notebook, okay? So I'm going to start now. I think we have like 6 slides. Okay, let's start. back again. Okay. Have you enjoyed? Let's answer these quizzes together. And I think Dr. Verma, please, you can unmute your mic. So Dr.
Yeah,
Verma,
excellent choice of music. You actually put a lot of effort in your presentation, Dr. Ghada. I must say that. I'm very motivated by your presentation.
Thank you, Dr. Verma. So Dr. Verma doesn't know these questions. I didn't show him this presentation. I can give you now the mic, Dr. Verma, to moderate these questions, okay? And, you know, because I'm not practicing these cases, and I think you will get a lot of information from him. but I'm going to moderate the questions. So just wait until we see their answers. So again, I think you wrote some answers. Please, it's time now to do in a chat. So in the chat, just give me the key answer for this slide. So these quizzes actually are all about observation. So it is a test for your observation rather than anything else. First, you have to notice what is the question. So here is the question, the question marks. And it seems to us we have at presentation and we have after something. Okay, after something. And we have the photo and we have imaging. Yeah, now Dr. Verma, it's your time to comment on the answers.
Yeah, so it is. I've seen most of them have written after decompression. Yeah. So the after picture, if you compare the clinical picture first, you can see obviously there is reduction in the amount of proptosis as in amount of the lid retraction. And if you compare on the CT scan, this is a soft tissue window CT scan on which you can see, if you see the lateral orbital wall, you can see there is only the anterior part of zygoma is left, where they have removed the middle part of the zygoma. And on medial side also, on the medial orbital walls, you can see the contour of the muscle. So the medial rectus muscle, the medial rectus which was going parallel to the medial wall in the upper picture, you can clearly see there is a bulge in the nasal cavity. So they're bulging out into the nasal cavity. So they have opened up the medial and the lateral wall, and this is what is known as a balanced decompression surgery. And also you can see even after decompression, this patient does not have any amount of residual squint. So if you do only one wall decompression, this patient ought to have a dystopia, then the extraocular muscles would bulge and this patient can have squint. So doing a medial and lateral wall together gives you a balanced orbital decompression.
Okay, thank you. Let's go to the next one. So, dear participants, now write the answer of this slide. Describe and signs. I think it's the same meaning. Again, we have like two scenarios, like two time frames for this photo. Like we have here and then here after something. Yeah. And now, Dr. Verma, please, can you comment on the answers?
Yeah. So distensible venous, as they all can see now in the photograph, that it's a distensible venous malformation, and it's basically a Valsalva maneuver proptosis of the globe. And on the MRI, I think this is a non-contrast MRI, so we are not clearly able to see the venous malformation. It's a dilated vessel, but clearly can't comment on the type of venous malformation and if it has any connection. So yeah, so the only thing that can be commented on this picture is the amount of increase in proptosis after Valsalva.
Okay. And yes, so remember, Dr. Vertesh, there is a specific classification for arteriovenous malformation, right? It's not only about varices. We have other classification, like they have to know about it, right?
Yeah, so venous malformations are now called as venolymphatic malformation in the broad term, and now they are classified into high grade and high flow and low flow malformations.
Okay. So there is a specific classification, and I think you can find it in iWiki. It's a nice article. And don't forget, because someone said varices, so don't rush to the diagnosis. If the question is about signs or just describe, start by describing. Okay. So for example, you can mention which view here. This is called what? It's Worm's view. You can say Worm's view, and you add additional information. So don't rush to the diagnosis. Describe first if the question is about description. Now, time to answer this quiz in the chat box. Describe and signs. Now, Dr. Verma, do you have any comment?
Yeah, so the giveaway is whether it's a left side proptosis or right side enophthalmos. And why do you call this as enophthalmos? Is that superior sulcus deformity that you see on the right side. That's a giveaway that this is not proptosis of the left, it is enophthalmos on the right. And then you can remember multiple causes of phenophthalmos back of your mind, that what do you have to keep in mind when somebody asks you of phenophthalmos, 3 or 4 important causes.
Yeah. So because we got an answer about proptosis of the other eye. So it's actually an ophthalmos of this eye. So next one. So what's the aim of this quiz actually? Sometimes the answer is on the photo. I mean, sometimes the sign is very obvious. If you look closely to this, you will find the name of this fancy device. Actually, it's written here. Okay. So I brought this quiz because to notice if you observed this answer here written or not. But it seems that nobody noticed it. Do you have any comment about this device, Dr. Verma?
I have never used it, but this looks like something to measure the facial symmetry, like as you can see, this patient is of slightly old age, and then you can see different scales that can measure the
everything.
The IPD, the intercanthal, everything basically. So basically to measure the facial asymmetry that is present in patients' aging face.
Do everything by measurements. Okay.
Yeah.
And next one. This is very important. So this is the most important quiz actually. And it's a tricky question. So I'm giving you a clue right now. Can you comment on the globe itself, like the cornea, the pupil? What do you think? Yeah, exactly. Excellent. So actually, this is a case of ophthalmos, and actually, this is pseudo-proptosis. Although if you did Hertel, you will find large numbers in comparison to the other eye. But since there is no mass pushing the globe, it's due to the large globe. It's just because of a large globe. So it's actually a case of ophthalmos. Okay, this is a pseudo-proptosis. How about this one? So is it dystopia only, or there is something else? We usually don't say thyroid when we have like such a dystopia. Can we mention thyroid in such, because she's a lady doesn't justify that she's a thyroid patient, because she has a lot of signs against thyroid. Okay. And again, don't say horizontal.
The biggest hint is the other eye.
So now you can.
Yeah, I mean that not to mention thyroid in this case, because the other eye is absolutely nothing. The other eye is completely fine. So
okay, so this is an additional point. Yeah, so you have non-axial proptosis. So don't forget proptosis, because we have proptosis, but non-axial because of dystopia. So again, if we draw here, it's temporal. If we like draw the midline here, and this is from this distance, definitely if we measure the distance from here to here, it's larger because this eye is pushed laterally. And you think of a pathology in the ethmoidal air sinus or the nasal orbit. And there is a lot of pigmentation here. This is actually an ominous sign. Mostly there is a malignancy here. But I don't remember the cause, and I think the reference doesn't mention the cause, okay? But it's not a benign cause, for sure. So this is not a salmon patch, this is a pigmentation, so you have brownish pigmentation. So let's make it larger here. This is like a melanosis, like something, maybe melanoma. So
with subconjunctival hemorrhage.
This is not a salmon patch. And if you want to comment on the Hirschberg test, it's central, by the way. So Hirschberg test, we usually think of Hirschberg test as a single dot in the center of the pupil, but also it depends on the flash. But here the photography used 2 points. So here it is 2 points straddling the pupillary border and almost the same on the other eye. So even despite of significant lateral dystopia, still the visual axes are aligned, by the way. So this is like an additional point. I repeat this slide, I mentioned it before, okay? So I'm talking now out of artistic point of view, not from an oculoplastic point of view, because imagine this is a case of thyroid patient, okay? But as you can see, imagine she has proptosis, but it has also hypotropia because of inferior rectus restriction. Some candidates, okay, unfortunately say this is an inferior dystopia, but this is not an inferior dystopia. It's just a squint. It's hypotropia. Okay? So don't rush at dystopia. If you remember, if we have dystopia, you have to search about 3 things, like swelling, like there is a swelling, evident swelling, pushing the globe to one direction, okay? And look at the fissure at the canthi, okay? So imagine this case, okay? This case, definitely there is inferior dystopia. If you imagine the fissure here, it's like drawn downward. Everything is shifted downward. And definitely there is a mass here, there is something here. So now try to compare this photo by this photo. This is just hypotropia. And the fissure is here, is like in line with the other one, okay? Because sometimes you get a case of axial proptosis with a squint, like with exotropia or hypotropia or anything. So please don't say it's dystopia. Dystopia, if we have like strong evidence that there is something pushing the globe and everything is displaced. Let's see another photo before we conclude this presentation. Again, try to use this clue. I am saying this clue is like artistic clue. If you imagine the palpebral fissure here, it's like down. Why? Because the globe itself is down. It's shifted down. It's hypoglobus. It's inferior dystopia. And there is some fullness here. In such a case, you can say there is dystopia. And if there is an associated proptosis, definitely this is non-axial proptosis. Now it's time for the last part, which is about some miscellaneous closing slides. And I hope you are still following me, hopefully. Again, if you remember, I've shown this slide before, 4 peas in a pod, remember? So if you remember, we said before, we have 4 topics are closely connected: orbits, lids, eyelids, pupils, and motility. Okay? And if you remember the checklist for orbits, you will find a point related to the eyelids, points related to pupils, and points related to motility. And in our next topic, which is about ptosis, you will find that in the checklist of ptosis, you will find points related to pupils and points related to motility and points related to the orbits. So they are like 4 peas in a pod, 4 peas closely related to each other, okay? And if you still remember, I said, remember, the letter P is an important letter when it comes to oculoplasty. And I said before that we will discuss this later on. And if you like mnemonics, you will find this mnemonics, kind of mnemonics in American Academy, that when it comes to proptosis, which starts by letter B, by the way, okay? And if you remember, ptosis starts by letter B. So again, in proptosis, we have 6 P's that you need to assess and to comment on each of them. First, we have proptosis. So whenever we have proptosis, there are other P's, 6 P's. The first P is proptosis itself. You have to decide whether the case is in pain or not, okay? Because if there is significant pain, you have to give the examiner explanation for such pain, whether it is inflammation, for example, or due to infection, or just because of in clinical practice, there is no infectious cases, I think, as they will not provide you with orbital cellulitis, for example, in the exam. But let's talk in general, like in your clinical practice, if there is pain, so you have to decide what is the cause of such pain, whether due to inflammation or infection or acute pressure change in the orbit, like retropalpal hemorrhage, for example, okay? Or whether there is like a malignancy with bone erosion or nerve involvement, something like that. Because, in medicine, we care about pain because we must provide the patient with something to relieve. We don't allow patient to suffer from pain, okay? So you need to decide whether it's painful or not, because one of the line of management will be about management of the pain itself, okay? In addition, of course, to the treatment of the cause, the initial cause. And sometimes it helps us to list the differential diagnosis according to the pain. You will get a list of differential diagnosis differs from other cause of proptosis that doesn't cause pain, like painless proptosis. And if you remember, thyroid is something in between, just discomfort, generally speaking. And the next P is progression. So you have to document whether the case is progressing or not. This is another P. And any preorbital changes, for example, in thyroid eye disease active phase, we have soft tissue involvement, okay? And here the two in violet here, palpation and pulsation, okay? So each one helps to reach the cause or, try to identify the proper list of differential diagnosis, okay? These are like basic 6 Ps written in American Academy. You can know more about each if you check the American Academy. Okay? So proptosis, pain, progression, preorbital changes, pulsation, and palpation, okay? And some add more, like past medical history is really important, like past history of anything, like trauma, for example, okay? And we can also add old photos or old pictures, okay? And, here I brought an image in 80s because, each decade, the photo for each decade has like a special tinge of color, just to add some fun. So old photos, sometimes we need old photos. So old photos sometimes helpful in oculoplasties and oculoplasty and also in strabismus. Or let's make it like broad and make it general, any imaging, any past imaging like CT, previous CTs, previous MRI, and so on. So again, it starts by P, all right? And now we have like what? 2, 4, 6, 8 Ps. And, I asked before in a previous post to add more Ps. And you said a lot of things starts by P, like the importance of pulse in thyroid eye disease, for example, the pupil, okay, it's pressure, whether the interocular pressure, generally speaking. Okay, so we have like pulse. It could be like the general pulse in thyrotoxicosis, or it could be the pulsation of the orb, but already mentioned in this violet shape, okay? All right. The pupil for RPD, which is an important sign for optic nerve affection. Additional Ps, if you remember, you said before many times, pseudoproptosis starts by P, okay? Any prescription glasses like high myopia for pseudoproptosis, any abnormal hip posture, so posture because there might be an abnormal hip posture because of associated strabismus. Also P for primary position alignment, so again, P. Okay, I will show you the comment below the slide. Okay, so as you can see here, when I asked you before to mention additional Ps, you give me a lot of things actually. I was like very astonished and very surprised by how many Ps that can be added to this kind of mnemonic. So pseudoproptosis, prescription, posture, primary position alignment, retropropulsion, okay, ptosis, palpitation, posterior pole examination, papillary changes or peripapillary shunt vessels, pretibial myxedema, proximal myopathy, perspiration in thyrotoxicosis, paranasal sinuses, we have to comment on photographic documentation, paresthesia, like in trauma of orbital floor fractures, palpebral pressure high. You gave me a lot of wonderful answers. I kept them in the comment below the slide. Okay, so back again to our presentation. So in this miscellaneous slide, here I'm just repeating some important information. And this photo is from a reference and very nice because it shows unilateral upper eyelid retraction. And you can appreciate whenever there is upper eyelid retraction, the dorsal show is narrow. Compare it with the other apparently normal side. Here it's wide. This is a normal width of the tarsal show, and here it is narrow. And as a result of eye retraction, we have a rim of the sclera is visible, and the vertical pupil fissure is larger or is more than the other side. Okay? And remember, we have different scenarios. You may come across a case of eyelid retraction alone, proptosis alone, or they could be both existed in the same case, like in thyroid eye disease. So thyroid eye disease is an example, a good example of proptosis and eyelid retraction. Okay, in the ptosis class, we will discuss the MRD1, the margin reflex deficient 1. At this point, whenever we have eyelid retraction, the margin reflex distance, which is the distance between the reflex of the corneal reflection and the margin, the upper eyelid margin, is increased. In ptosis, we will get the opposite. So the margin reflex distance in ptosis is decreased. So again, in upper eyelid retraction, the MRD1 is increased, while in ptosis, the MRD1 is decreased. Again, I showed this slide before, because of this dangerous complication, sight-threatening complication of cornea exposure. We need to check for corneal protection mechanisms whenever we come across a case of proptosis. And if you remember, we mentioned this before, we have to test for Bell's phenomenon, lack of thalamus, sensation, and staining. And you know what? We can add also Schirmer test. In your practice, of course, you will not allowed to do Schirmer test in the exam, but this is for practice. Okay, you have to also have an idea about the tear film. Especially sometimes some of the orbital disorder can affect the lacrimal gland, the main lacrimal gland. So Schirmer test actually serves two purposes: to give you an idea about the tear film. So this is an important protective mechanism for the cornea. And again, it might be affected due to an orbital disorder affecting the lacrimal glands. All right. So again, here in this photo, as you can see, this is the kind of exophthalmometer, okay? Just a reminder once more that exophthalmometer is a kind of misnomer, because we can use it to measure not only proptosis, but also ophthalmos. And since we apply the foot plate here at the lateral orbital rim, it can be used also to measure the distance between the two lateral orbital rims to diagnose any kind of abnormalities like hypertelorism. So I said this before. In any kind of exophthalmometer, there must be two lines or two marks to help you to take the measurement with zero parallax. Parallax, if you remember the parallax, I mentioned it before in a previous class, but it's not evident in this photo. It's not clear, but here you can see, here we have like a conical triangle here, and actually there is another mark above. So the apex of this conical or triangle should coincide with a marker above before you take the measurements in order to ensure zero parallax, okay? All right. So again, it's almost impossible to do Hertel measurement accurately and quickly for the first time during the exam. You have to practice using it before the exam. But according to many experiences, it's okay if you can say to the examiner that you don't know how to measure. You know that only the principle in theory, but you don't have actual practice like hands-on using Hertel. And in such a case, you have to be ready with a ruler so you can measure the amount of proptosis by a rule. Okay. This is the photo of Hertel ophthalmometer as it was shown in my video. Remember, if we have proptosis with a squint, it's better to occlude the fixating eye in order to help the squinting eye to fixate, okay? And then do the measurement of proptosis, okay? So once more, suppose you are now measuring the protrusion of the left eye, but the left eye is exotropic. So you can ask the patient to occlude the right eye in order to help the left eye to fixate, to be like aligned in the primary position, and then do the measurement. Also, if we have significant dystopia, it's better to use a ruler rather than exophthalmometer. Again, here another statement to stress the importance of taking the reading to no parallax alignment position as possible. And this is the photo of Lud exophthalmometer, which I had back then when in my exam. It looks simple, but it's genius, okay? It's a genius exophthalmometer. There is one end is indented, which you applied on the lateral orbital rim, and you have like scale above, like two scales on each surface, okay? So one is used for the right eye and the other one for the left eye, but we have two scales on the other side also. Maybe it's not visible in this photo, but actually, as you can see here, there is a scale above and a scale below, one used for the right eye and one used for the left eye, but we have the same scales, the same two scales on the other surface, in the under surface. And why is that? Again, for the same principle, because you need to take measurements with zero parallax. And if you have two scales and two surfaces, yeah, make sure that
the two scales coincide with each other before taking the measurement, before observing the number at which the corneal apex point is at, okay? I don't know, maybe you couldn't understand me right now because sometimes we learn things in practice. It's very hard to just say it. You have to apply it on a patient or in a volunteer. But anyhow, the bottom line here that even in such simple exophthalmometer, we can do accurate measurement with zero parallax because of the presence of the scales on both sides. All right. So we have here in the upper photo kind of Hertel exophthalmometer, and here Lued exophthalmometer. Suppose we have an issue with the lateral orbital rim, and in other words, there is another exophthalmometer. Yeah, I wanted to know. Actually, there are a number of exophthalmometers in the market, but here this is the one, a famous one. Also, it's called Nogel's exophthalmometer. Okay, Nogel exophthalmometer. Let's write down the name here. Okay, it doesn't require normal lateral orbital rims. So in patients with lateral orbital rim defects, okay, it's recommended to use Nogel's exophthalmometer. The exophthalmometer rests here on the forehead, okay, and the cheekbone or the maxillary prominence. And the supporting points here is opposite to the pupillary area, okay? But even though still we observe the protrusion of the corneal apex from the lateral orbital rim. So the fixation points here is slightly above, okay, and slightly below the superior orbital rim on the forehead and the maxillary prominence or the cheekbones. But if you notice the photo below, it looks like this part looks like Hertel exophthalmometer. The same idea. We have here a red marker and we have here a clear bar, and both should be aligned before taking the measurement, before observing the corneal apex, the number at which the corneal apex points at. But here in Nogel's exophthalmometer, we record the number in each side, and we depend only on the difference between both sides. So in contrast to absolute measure that we can obtain with Hertel, here in Nogel's, we depend on diagnosing proptosis by noticing the difference, the relative difference between each eye, okay? So once more in summary, so in Nogel's, the fixation points here are not on the lateral orbital rim, but on the forehead and cheekbones. But here, when we measure the protrusion of the globe, it's the same idea as Hertel, but we don't say when the corneal apex is more than 22, for example, millimeter, it's proptosis. Why? Because here the patient already has a problem in the lateral orbital rim, but we depend on the relative difference between both measurements. And also, because there is another scale here, vertical, it can also allow you to measure the vertical dystopia. And it's said to be more comfortable. So this Nogel's is more comfortable in measurement than Hertel, because in Hertel, there is a foot plate on the lateral orbital rim and there might be touch of the globe, but here the supporting points is away from the globe, actually. You can know a lot of information regarding Nogel's exophthalmometers. Actually, there is a YouTube video by the Nogel's himself talking about the advantages of his exophthalmometer. Okay, since the repetition is the key for, for getting the best of anything, here again, the most important question to be asked in proptosis, is it true or pseudo or both? The second question, is it axial or non-axial? Okay, in axial proptosis, there is no dystopia. In non-axial proptosis, there is a combination of proptosis and dystopia. Again, this is a checklist I made before, but you know what? The best checklist is the one you do by yourself, okay? So, but please, you can add extra points, but don't remove any of these points. And you can make some different order, but again, you have to start by observation, followed by measurements, all right? And don't forget things like palpation and pulsation, and so on. Another way to increase your depth of knowledge and make you more smart at approaching any case, whether in your practice or in the clinical exam, is to have in your bookcase some books that discuss cases. Okay, it's an old book, but it's an excellent book actually. It's Ophthalmology Pearls, and this done by Janice Gold. It's the same author for Ophthalmology Secrets, a well-known book. So this Ophthalmology Pearls, you will find cases like a common scenarios of cases like this one. It starts by a heading like a 50-year-old man presents with painless left globe proptosis. Okay, and it will provide you with a photo of the case. And as you can see here, this patient, although the title is left proptosis, but you may think there is no proptosis. Why? Because there is no lid retraction. Actually, there is actually ptosis in this case. And that's why we always say that ptosis can mask proptosis. It's a kind this sentence is has a bit of a rhyme or like a musical tune, that ptosis can mask proptosis. Okay, and then after the title, you will see a small hint about the case. Okay, and as you can see here in Worm's view, now the proptosis is evident, because when the proptosis is unilateral, it's very easy to diagnose it because you can compare it with the other apparently normal sign. So again, here the proptosis is masked by the ptosis, okay? But Worm's view solved and confirmed the presence of proptosis. Of course, you need to do measurement later on. And back again, so you will find a hint about the case. Okay, and then after a hint, she will provide you with some points regarding the examination. So you can learn how to comment on what are the important points to be assessed in the examination. Okay, I will leave the slides for like a couple of minutes so you can read it. Okay. And even sometimes you will find imaging and like what are the diagnostic findings. And you will find also some questions. And the model answer for the questions. The greatest thing about these cases, they are simple cases, common scenarios, and they are solved. They are solved. So you will know what is the cause of proptosis, for example. And it provides you with some important follow-up questions. Like the case turned out to be cavernous hemangioma, and this is from the American Academy. Yeah, so the more photos you watch, the more cases you witness by yourself, you will become more knowledgeable, and you can go to the exam without any stress, or at least like minimal amount of stress. Again, back to dystopia. So all what we discussed so far actually is called globe dystopia, because we are talking about displacement of the globe either vertically or horizontally. So we are referring to the globe position. But if you study in depth, you will find something else, something more advanced. Maybe Dr. Verma is, possibly dealing with such cases. We have like more complicated cases where there is an orbital dystopia. So the bony orbit itself is not a normal, is not aligned with the other, maybe because of the trauma, or I don't know, or maybe of congenital syndromes. So the orbital dystopia means the bony orbit itself, the anatomy of the bony orbit is like displaced. It's not a normal anatomy. And we have one dystopia left, which is foveal dystopia. So foveal dystopia, if you have watched my series, other series about strabismus animated
illustrated series, when we talked about abnormal angle kappa and when we have like abnormal position of the fovea, maybe there is a cicatricial scar due to ROP, maybe causing temporal dragging of the fovea. So whenever we have displacement of the position of the fovea, we can call it also foveal dystopia. So we have 3 dystopias, as far as I know, in ophthalmology. But interestingly, dystopia is an English word, and it means a word in which people led fearful lives. And it's the opposite of utopia, which is imaginary perfect place. Nice word. Another miscellaneous slide, and I posted before. If you can notice, the answer here is something, another entity called globe laxation. Okay, so mostly you can expect the globe laxation if you imagine, if you just think about optic nerve avulsion. If you have an optic nerve avulsion, like complete avulsion, the globe itself is displaced beyond the palpebral fissure. Okay, the palpebral opening. So the globe equator is beyond the palpebral fissure, and this is we don't say this is proptosis. So don't write down in the patient's file this is a proptosis. No, this is not a proptosis. This is called globe laxation. It could be traumatic. It could be non-traumatic. Okay, and I have seen. Yeah, I think you can see such cases like traumatic optic nerve avulsion with globe laxation maybe once or twice in your lifetime. They are miserable cases. The most important is never ever think to remove the globe. Okay, oculoplastic surgeon will do every attempt to return the globe inside the orbit socket. Okay, I always imagine this is like a delivery of baby. Like it's very hard. It's very tough to replace the globe, and that's why we need oculoplastic surgeon to return the globe inside the socket. It could be trauma, it could be non-traumatic. It's reported non-traumatic causes. And if you check the literature, it's recorded also in cases of thyroid disease. So again, what's the meaning of globe laxation? It's displacement of the globe, and it's not due to mass. There is nothing pushing the globe, okay? Mostly due to the optic nerve avulsion. So I just wanted to share this interesting term, globe laxation. So we have laxation of the globe, and we have laxation of the lens subluxation in ectopia lentis, if you remember. All right. Another miscellaneous slide. Okay. We are almost finished, which is one of my terrible jokes that I want to share with you. I'm not good at telling jokes in English, but let's give it a try. Maybe Doctor, who is speaking nicely, Doctor? I think I appreciate someone's speaking skills. There is one participant.
Yes, doctor.
Who is I said before, there is one is telling a story nicely, like it's reading like as you. Okay, I give you the chance. It's my brainchild joke, but I give you the privilege to read it. Okay.
Okay.
Get ready. Yeah. Go ahead.
Okay. An orbit case. Thyroid eye disease, proptosis, squint. Examiner. How would you manage proptosis? Candidate. I'll refer the case to an orbit surgeon. Examiner. How would you manage strabismus? Candidate. I will refer to strabismologist. Examiner. What shall you do for the thyroid status? Candidate. I will refer to endocrinologist.
Okay, since you are very excellent at telling and reading, so you can imagine the gist, the bottom line. Yes. So what do you think the examiner will say at the end?
Yes. I think I will refer you to the next exam venue.
Yeah, exactly. So it's not ever enough to say I will refer. Okay, so I refer means I don't care. So whenever you say I refer, you have to say the line of treatment. You have to say something. I refer the case for orbital surgeon to do decompression, and we have like balanced decompression and so on. And the case has hypotropia. I refer to a strabismologist to do inferior rectus recession after forced abduction test. You have to show the examiner you have the knowledge. Although you will not do the case by yourself, but you have to show the examiner that you have the knowledge. Okay, and sometimes the answer is very simple, like what? Like the order for in thyroid eye disease, whenever we have an order, if you are going to do orbital decompression, to have to do it first, followed by strabismus surgery, and followed by the eyelid surgery. Okay, sometimes the answer is very simple. Don't say I refer without mentioning anything. Personally, I like to use in collaboration. So I try to omit the word refer, and I use usually in collaboration with endocrinologist or in liaison. So liaison is the same meaning, in collaboration or in liaison with orbital surgeon and so on. Okay, all right, and yeah, I think I finished about like 70% of what I was planning to say, but it's okay. So we finished proptosis, and the next topic, as you might expect, is my favorite. So the most favorite topic in oculoplastic is ptosis. Actually, I practiced ptosis surgery on a small scale for a few years during my medical doctorate. Then I quit because I believe that oculoplasty is the most difficult subspecialty and the most stressful, especially if it is combined with oncology. So in the meantime, until we join again for the next class, I advise you to revise the chapter of eyelid, including the trauma, and try to revise and do your own work and do a checklist. How could we evaluate, what are the points to be assessed in a case with ptosis. The last activity in this presentation, and then we'll close up the meeting, is this one. Okay, so I'm going to send you a Google form. Okay, so this Google form, you will find a number of MCQs. Okay, so I know your exam isn't in the MCQ format, but sometimes we learn a lot of things from solving MCQ. So you will find a number of MCQs regarding proptosis, okay, except for one, and you will view your score. So it's generally assess your overall knowledge about proptosis, okay. So then I will send another form when you will find the discussion, the explanation for the answer for each question, okay. So I just sent the Google form. Just click on the link to see if it is open or
it's open.
Okay, now start to solve the questions. Most of the questions were taken from the American Academy. They are well-written MCQs. Whenever you feel bored from studying, during your preparation and the exam is still not coming soon, you can solve any MCQ questions. They are always interesting and enjoyable way of studying. Okay, I think I can end the presentation, and I leave you solving these questions and to view your score on your own. All right. Thank you for attending this meeting. I'm sorry for keeping you too long.
Thank you.
You're welcome. And have a nice day, and I hope to see you soon. And thank you, Dr. Kushik, for being with us today. And thank you, many thanks to Dr. Verma for your invaluable inputs throughout the presentation.
Thank you so much, Dr. Ghada. Thank you.
You're welcome. I shall end the presentation right now. Goodbye. Bye-bye.